Okay, so Assalamu alaikum everybody. Hope you guys are doing good. My name is Adam Khawli. I'm a second year medical student. Along with me here today,
Feras Namour. I'm also a second year medical student, and together we will be teaching you guys or like overviewing all of FND OSPE, inshallah. I hope you guys are doing good. You guys are studying well for your exam, and bear with us, inshallah. This OSPE review will cover everything OSPE related, and you guys can revise the file later on as it contains, inshallah, everything that you guys would need. We made it as simple and as straightforward as it can be, and it covers everything, bismillah. So hope you guys are doing good and studying well, and best of luck on your exam. Don't worry, everyone is also going through exams. We have POD, 30s have CVP, so this is we are all going through it. Inshallah khair and bitbarri يعني bismillah, and let's start.
okay, so before we begin with the actual slide, we just want to give a quick overview on what OSP is. So basically everything you took in labs, you'll be tested on it. But the thing about foundation is that it's online. So basically everything will be on the iPad, exam soft. And the thing about OSP is the same as TBL. So there's no backward navigation, meaning whenever you click next and go to the next question, you cannot go back to the one you answered before. So a quick tip, you answered a question, you press next. You thought you did something wrong, forget about it. Focus on what's in front of you. وإنشاء تتيسر يعني.
Exactly. No, you guys will have around like 30 minutes to solve 20 questions. You may think, no, it's the end of the world, but trust me, it's not. Yani. When you see the question, if you know it, you know it, okay? If you don't know it, don't stress on it a lot. Just don't waste precious time, basically. Move on to the next question immediately, and inshallah, you guys will go through it. Some questions don't take a lot of time. Don't overthink. Don't think too hard about it, come on. If the question takes 10 seconds, 20 seconds, yalla, move on. The next one, outward. And again, backward navigation is mafi. It's similar to TBLs, so be careful with your answers. Like revise them before going, and if you don't know it, don't stress. Yalla, next one immediately.
And make sure to keep track of your time, okay? You have around 30 minutes for 20 stations. So are you guys ready to begin?
Any questions?
Any questions about OSP in general before we start?
Be in the chat, few texts.
Where can I find the slides? We will be sending them out, inshallah. And yes, inshallah, if you study from this file itself, inshallah, you're good for the OSP.
Like if you guys can revise for OSPE to this file, okay? Go back to your lab material, to your like histology slides and lectures and everything. Revise everything before the OSPE. Like tomorrow, the day before the final, go through everything, and inshallah, you guys will do really good. Bismillah.
Is it just the OSP? Yes. So for the final, the OSP is the only part that has no backward navigation. So the SAQ and the MCQ, you can go back to the questions you have before. Yeah. So let's begin. Bismillah ar-Rahman ar-Rahim. So there are a lot of slides in this PowerPoint, but we try to simplify everything as much as possible. So that's why we're going to find like different topics in different slides, okay? So, okay, let's first start with anatomical terminology. So first off, we have something called superior, something called inferior. So superior, from its name, means above, okay? So for example, the brain is superior to the heart. Now for the inferior, means below, okay? So the heart is inferior to the brain. We're just gonna go through this part really quick, just for the complacency's sake. We just included this here so that you can memorize everything in this file alone, okay? So ventral means anterior and dorsal means posterior. An easy way to remember this is D before, or in other words, behind V. So D is posterior or to the back, and V is anterior or to the front. So for example, the heart is anterior to the spine, and the spine is posterior to the heart, okay? Medial, it means towards the middle. So towards the middle of your body. So the heart is medial to the arm. So it's more to the middle of the body than the arm, okay? Now for lateral, it means away from the middle. So the arm is lateral to the heart, means it's away from the middle, which is the heart, okay? Intermediate means in between. So basically the aorta is intermediate to the heart and arm. So if you look at the numbers right here, you can see that the 5 is in the middle, 6 is to the outside, 7 is in between the 5 and the 6, okay? Now for proximal, it means close to. Distal means far from. What does that mean? For example, the elbow is proximal to the wrist. So the elbow is really close to the wrist. whereas the knee is distal to the shoulder. So there's a really long distance between them, okay? Remember this as D for D, distal for distance, yeah? Superficial means towards the outside, so the skin is superficial to the muscles. Deep means towards the inside, the muscles are deep to the skin. I'm not sure if you're going to be asked about that part much, but just for the sake that we completed everything, we're just going to go through them all quick, okay? Now for the planes. The sagittal plane means that it divides the body into left and right sections. So basically, the sagittal plane is dividing you from the front, from your nose, okay? Into left and right. Now, what does mid-sagittal plane mean? Can somebody tell me the difference between sagittal and mid-sagittal? Mid is equal parts. Yes, exactly. So basically, mid-sagittal means it's exactly at the middle of your body. So basically, there's an equal left, equal right. Whereas the sagittal, which is not mid-sagittal, just the normal sagittal, it could be anywhere. It could be here, it could be here, it could be here. So the difference between sagittal and mid-sagittal is that mid-sagittal is at the midline, exactly at the midline. It's a nice question to bring in the OSPE. They might try to trick you. But remember the difference between normal sagittal and the mid-sagittal, okay? Now, for the frontal plane, it means that it divides the body into anterior and posterior. So an easy way to remember this, frontal, front and back. Another word for it is coronal. You need to memorize both. They might bring either one, or you might ask you to write either one. So basically, it divides your body from the top through your entire body, front and back. For the transverse plane, it will divide your body straight, like this. So basically, you're going to have a superior part and an inferior part. Do we have any questions about these parts that we just explained? Everything is straightforward. Everything is just memorization. Okay, moving on. We're going to go into muscles now. Now, this is a really high yield topic for OSPE. I guarantee that you're going to get at least one question about muscles in the OSPE, okay? So let's start with the first type, parallel muscles. What does parallel mean? It means that they run along the same line. So basically, I have a line running this way. All the muscles will follow it. So if you look at this picture right here, you can see all the fibers or the fascicles. They're the same name for both. They run in the same direction. They're all parallel to each other. And there are two examples that you're supposed to memorize here. There's the sternocleidomastoid muscle, which is found in the neck. It's this muscle right here. And there's the sartorius muscle, which is in the leg. It's this small muscle right here. Now, in our OSPE, the 16th batch OSPE, they got this muscle. They asked us, what type of muscle is this? And name it. So most of us put neck muscle because we did not know that it was a really high yield topic. So make sure you memorize the names of each example that you take, okay? So for parallel, we have sternocleidomastoid and sartorius, okay? Now for the fusiform is fibers that are still parallel to each other, but the main difference is that this muscle has a belly. So an easy way to remember this, fusiform, F for fat muscle. So basically the muscle has a belly at the middle. Two examples again, the biceps brachii, which is the biceps muscle on your arm. It is a type of fusiform muscle. And you have the digastric muscle, which is found right beneath your mandible, which is your jaw. Okay? For the circular muscles, the fibers are in circular arrangement from their name, circular. So basically they are going all the way around. Now, why is this muscle important? Because it forms a sphincter, or in other words, an opening. So when the muscles contract, they will close this opening. When they relax, they will open this opening. Muscle that you're supposed to remember is the orbicularis oculi muscle, which is found in the eye. So basically this muscle, when it's contracted, it closes the eye. When it relaxes, it opens the eye, okay? Now for the triangular, or in other words, convergent muscle, there's only one example for this, which is the pectoralis major, which is on your chest. And what's the definition of this muscle? It has a broad origin. So you see how many different origins there are, with fascicles converging into one single tendon. So basically many origin points, many different fibers going into one tendon. So if you look at the cadaver right here, you can see how big this muscle is, and it all converges into one little tendon right here, okay? So triangular convergent pectoralis muscle, pectoralis major on your chest, okay? Now for the pinnate muscle, it's divided into three parts. And the definition of a pinnate muscle is a fascicle that attach obliquely to its tendon. So if you look at this one right here, you can see the tendon runs in the middle, and you can see how the fibers are running obliquely. So basically, let me just try to draw. You have the tendon right here, and you have the fibers going out in this direction, going oblique to it. Okay. Now, if the fibers are going out in one direction, it's called unipennate. And two examples that you're supposed to remember for unipennate: extensor digitorum longus and flexor pollicis longus. There are really difficult names for now. Well, I know that you guys might find difficulty in memorizing them, but you're supposed to memorize them, okay? Extensor digitorum longus and flexor pollicis longus. That's the unipennate muscle. For the bipennate muscle, it means that the fibers are going in both directions. So if you look at this one right here, you can see the tendon is in the middle, and the fibers are running obliquely at both sides. And an example of this is rectus femoris muscle, which is found in the leg. Okay? You need to memorize this. Please make sure to memorize the examples, because they might ask you what type of muscle is this, and then you're going to tell you, give me an example. So basically, A, type of muscle, you're going to tell them bipennate. Do not say pennate, say bipennate. And then they're going to tell you, give me an example, you're going to say rectus femoris muscle. Okay? For the multipennate, an easy way to remember this is basically multiple bipennates converging into one large tendon. So you have one large tendon right here and multiple bipennate muscles going out of it. Okay? And the muscle to remember this is the deltoid muscle, which is one found right here on your shoulder. Okay? Let me just remove the drawings. Okay. So we're done with the muscles. Do you guys have any questions, or do you want me to repeat any of the topics that we just went over in the muscles? Feel free to ask. We're here to help. So whatever question you have, make sure you ask it. All clear? Okay. If you have any questions, we're going to answer it later on as well. It's okay. So moving on, we're done with the muscles. We're going to enter into bones now. So there are two types of skeletons. We have the axial skeleton, which is basically the one that's in the middle. It's made up of the skull, hyoid bone, rib cage, and vertebral column. And then you have the appendicular skeleton, which is everything that's connected to the axial skeleton. So basically the upper extremities, as well as the shoulder girdle, the lower extremities, as well as the pelvic girdle. Okay? Now, this was an objective in your labs, so I'm just going to go over it one more time. Axial skeleton is made up of the skull, vertebral column, rib cage. Whereas the appendicular skeleton is made up of the upper and lower extremities, the shoulder and pelvic girdle. Okay? Now, types of bones. First up, we have the long bones. These bones are longer than they are wide. So basically, they're called long bones. Okay? Now, we have three types of long bone. We have the normal long bone, which is just a really large long bone. And the examples that you're given are humerus, radius, ulna, femur, tibia, fibula. Now, I'm pretty sure they're not going to ask you to name this exact example of a bone. They're just going to tell you what type of bone is this. You're going to say long bone. And then B, they're going to ask you, give me an example or two examples. So just make sure you memorize at least two or three of the normal long bone examples. Okay? For the other type of long bone, we have the miniature long bone, which are basically long bones, but they are really small in size, so they're called miniature long bones. These bones include the metacarpals, metatarsals, and phalanges. What are the metacarpals, metatarsals, and phalanges? You see your fingers. The metacarpals, they are the first bones right here on your knuckles, so sort of your knuckles. After that, you have the phalanges, which are the three bones found on your arm, or on your finger, sorry. Now, the difference between metacarpal and metatarsal, metacarpal is the one for the hand, metatarsal is the one for the leg. Okay? So inshallah, that's a simple way to put it, or an easy way to imagine it. But inshallah, it's an easy way to memorize as well. So miniature long bones, metacarpals, metatarsals, phalanges. Modified long bones, these are long bones, but they're not straight, they're kind of curved. An example of this, and it's the only example, the clavicle, which is the bone that's right here on your shoulder. Why is it called a modified? Because it's going inwards and then outwards, so it's kind of curvy, So long bones, three types: normal, miniature long bones, modified long bones. Okay? Now, the other type of bones is the short bones. They are cube-shaped with vertical and horizontal dimensions approximately equal. They're basically shaped like a cube. So you remember how we said the metacarpals and metatarsals of your arm? You see these ones right here? These are the metacarpals. You see how they're long bones, but they're miniature? You see the ones that are right here, right in this area? Let me get the pen. 1 second. You see the ones that are right here? These are called short bones because they're shaped like a cube or really short shaped. Now for the leg, they're called tarsals, which are these bones right here. You see them? And these right here are called the metatarsals, miniature long bones. I hope that made it easier for you to visualize it. The difference between long and short bones, it will be clear, inshallah. Now, flat bones. Flat bones, they are thin and flattened. It does not mean that they are not curved. So a rib is a type of flat bone. Okay, this might be a trick question they might bring in the OSPE. What type of bone is the rib? It's a flat bone. Even though it's curving around, it's still considered a flat bone. Okay. Another type is the sternum, which is the one we have found right here. And the third type of flat bone is the scapula. Now remember, scapula is not an irregular bone. It's a flat bone. Okay. This is also another tip, a trick question they like to bring in the exam. And the scapula is found on the back of your shoulder. Now, the sesamoid bone. There's only one example of this in the body because the sesamoid is a bone that develops within a tendon. So basically, the only example is the patella, which is the really short or small bone that's found in front of your knee. So the only example, sesamoid, patella. Okay. Now for the irregular bones, the scapula is not an irregular bone. Again, okay, please. So bones that are not in any of the listed categories that are above, basically they're in the league of their own. They're similar to each other, but they're not similar to anything else. The first up, we have the vertebra. They look nothing like anything we discussed before. Sacrum and coccyx, basically they look nothing like what we discussed before. The mandible, which is the jaw, and the hip bone. You see how irregularly shaped it is. It has many ins and outs. So you need to memorize the examples, and you need to know what type of bone this is. Okay. Now you have the pneumatic bones. Basically, pneumatic bones means bones that are hollow. They contain sacs of air. Okay. An example of this is ethmoid and maxilla. I don't think they're gonna ask about this. It's a really loyal topic, but just know it. Ethmoid and maxilla are pneumatic bones. Okay. Now we finished discussing about the bones. We're gonna go into vertebrae now. Do you have any questions, or do you want me to repeat any topics about what we discussed right now for the bones? All good. Okay. Now the vertebra. They might ask you short bones. Yeah. Okay. 1 second. Let me go back. Okay. So for short bones, the difference between long bones and short bones is that short bones are shaped like a cube. They're cube shaped. Okay. The examples are the carpals, which are the bones that are found in your hand, and the tarsals, which is the ones that are found in your foot. Okay. So please remember these two types: tarsals, carpals. Okay. They're called short bones because they're shaped like a cube. Is that clear, or you want me to do it in another way? Thank you. You're welcome. Okay. So the vertebra, we're going to discuss how to differentiate between the three types of vertebra. Okay. So first up, okay, we have the cervical vertebra. Cervical vertebra basically is the one that's in your neck region. And then you have the thoracic vertebra, which is the one that's in your thorax, basically behind your chest area. You have the lumbar vertebra, which is the one that's in your abdomen. Okay. So now we know the location of the three. How do we know, or in the exam, if they bring me this type of vertebra, I know it's a cervical vertebra. But what did indicated that this is a cervical vertebra is that it's the smallest. So you see the cell body right here, or not the cell body, the vertebral body, sorry, is the smallest out of all the three. So it's really small. And it's oval shaped. So if you look at it, it's kind of circular. It's really oval shaped. Okay. So it's easy to differentiate if this is cervical vertebra, thoracic, or lumbar just by looking at it. But there's going to be another part. So A, what type of vertebra is this? B, how did you know? Give me two examples of how did you know. So it's the smallest. The vertebral body is oval shaped, and it has a large triangular foramen. What does a foramen mean? It basically means this part right here. You see this opening? It's triangular and it's really large. Okay. For the thoracic vertebra, it's between the two. So basically, it's medium-sized vertebral body. It's not really large. It's not really small. And if you look at it, it's kind of heart shaped. So I'm going to try to do it here as well. It's kind of heart shaped. You see that? So the vertebral body is heart shaped. That's another way to differentiate the vertebra. And then the foramen itself is small and circular. So this is the only vertebra in which the foramen is circular. Okay. So three ways to differentiate the thoracic vertebra. Now for the lumbar vertebra, it has the largest vertebral body, and the vertebral body is kidney shaped. So basically the kidney looks something like this. So if you look at the vertebral body, it's shaped like a kidney. Okay. And the foramen is small and triangular. So the difference between the cervical and lumbar is that the cervical is large triangular and the lumbar is small triangular. So I'm going to go over this really quick because it's a high yield topic. Okay. 3 types of vertebra: cervical, thoracic, and lumbar. What's the difference between the cervical, thoracic, and lumbar? First off, let's talk about the cell body. The cervical has the smallest cell body, thoracic has the medium size, lumbar has the largest cell body. Sorry, not cell body, vertebral body. Now, the vertebral body itself, how is it shaped? In the cervical, it's oval shaped. In the thoracic, it's heart shaped. And in the lumbar, it's kidney shaped. Write it in the exam, kidney shaped and heart shaped. You're going to count it correct. And then a third way to differentiate is the foramen itself, where the spinal cord passes. The cervical is large and triangular. Thoracic is small and circular. And the lumbar is small and triangular. Okay? Do you guys want me to repeat them again? Or is there any point that's not clear? Okay, so moving on. I found this really nice image on Instagram Reels. So an easy way to remember it is the cervical is an elephant. Basically, it looks like an elephant. Thoracic is a giraffe, and lumbar is the deer. Okay. So basically, in the OSPE is going to be what type of vertebra is this? How did you know? Give me 2 examples. So at least get half of the mark by remembering that this is elephant, this is giraffe, this is a deer. Okay. Now we're going to talk about the relationship between the spinal nerves and the vertebral column, the vertebral spine. Okay. So in the cervical region, which is C1 to C8, the nerves are called C1 to C8. However, the vertebral bodies are only up to C7. What does that mean? I'll try to go to the next picture first. So in the cervical region, and only in the cervical region, the nerve that's above the vertebra has the same number. What does that mean? So always, when you're looking below the vertebral body, add 1. So we have C1 above C1 vertebra. Below it, if I add 1 to 1, I'm going to get cervical nerve 2. Below it is cervical vertebra number 2. Add 1, cervical nerve number 3. Below it is cervical vertebra number 3. And so on until you get C7. Why is this important? Because let's say I got a question in the OSPE. A person was in an accident and the C7 vertebra pushed upward. So basically it's compressing the nerve that's above it. What nerve will be compressed? You're going to say cervical nerve number 7, not number 8. Why? Because the nerve that's above the vertebra has the same number. Why is this important? Because this is only in the cervical region. Let's look at the thoracic region. You have the T1 vertebral body. The nerve that's below it is the thoracic nerve number 1. Let's look at T7. The one that's below it is thoracic nerve number 7. Same thing with the lumbar region. You have L4 vertebra. The one that's below it is the lumbar nerve number 4. Okay? So I'm going to give you a question. A person was in a car accident and his thoracic vertebra was crushed. Turns out that in the x-ray, the T5 vertebra was pushing upwards. What nerve will be damaged? T4, exactly. So the T5 cell body, sorry, not cell body, vertebral body is pushing upwards, so the T4 nerve will be damaged. Okay? I'm going to go over this topic really quick because it's really important. Yeah? So in the cervical region, you have 7 vertebral bodies, 7 bodies, and you have 8 nerves. The one that's above the vertebral body is equal. What do I mean by this? Vertebral body, number 1. So this is C1 vertebra, okay? Above this, I have the C1 nerve coming out. Below it, I have the C2 nerve coming out, okay? Why is this important again? Because it's only in the cervical region. So let's look at this vertebra right here. This is T4, okay? What nerve is above it? T4, T3, T7, T6? What do you guys think? T3, exactly. So above T4, we have the T3 nerve. Below it, we have the T4. Okay? Cervical, the one above is equal. Thoracic, the one below is equal. Lumbar, the one below is equal. Okay? Make sure you memorize the difference between the two. Do you want me to go over it one more time, or is it clear? Okay, one more time. Let me just put a blank screen so that I can go over it on my own. 1 second, let me try to figure this out.
Add a new slide.
Okay, 1 second.
Yeah.
Okay. So I have my cervical region. Yeah. I have C1, C2, C3, C4 until I get C7. So there are only 7 vertebral columns in the cervical region of my vertebra. Okay. My thoracic region, I have T1, T2, T3, and so on. In my lumbar region, I have L1, L2, L3. In my cervical region, even though I have 7 vertebral bodies, I have 8 nerves. Thoracic has 12, صح? Okay. In the thoracic, I have 12 columns. And I have 12 nerves. So they're equal to each other. Okay? Same thing with the lumbar. What does this mean? It means that in the cervical region, this is C1, this is C2, C3. Okay? An easy way to remember this. Cervical is in your neck area. It's the highest point in your body, your head. Okay? So C1, always above. Okay, remember this. C1 is above, so the nerve is always above. C1, you have cervical nerve number 1. C2, you have cervical nerve number 2, that's above it. C3, cervical nerve number 3, which is above it, until you get to C7. Okay, let's imagine this one here is C7. We said above it is C7, cervical nerve number 7. However, there is also a nerve below it. Why is there a nerve below it? Because after this, I have the T vertebra, the thoracic vertebra. So we said the thoracic vertebra, it's below. So T1 vertebra, the T1 nerve is below it. So this space right here between the cervical and the thoracic will be empty. So subhanallah, we filled it out with an extra nerve, which is C8. It has its own function as well. Okay, so cervical above, the nerve is above the vertebral body, it's equal to it, the same number. Everything else is below. Okay, I hope it's kind of clear now. Is it? خلاص ان شاء الله. I go back to it again. Okay.
Remind, because we have a lot to cover.
Exactly. Okay. So on the topic of spinal nerves, this is a really important topic as well in the OSPE. Okay. I'm 99% sure they're gonna get a question about this. So the spinal nerves themselves. Easy way to remember this: same day. 1 second. Same day. Sensory for afferent, motor for efferent. Okay. And what is the function of the Dave? Dorsal is afferent, ventral is efferent. So basically, the dorsal afferent is sensory. The ventral efferent is motor. Do you understand the mnemonic same, Dave? Same, sensory afferent, motor efferent. Dave, dorsal afferent, ventral efferent. Okay, so let me just make a new slide as well really quick. And let's draw it together. Okay, so I have my vertebral column right here. Wait, let me draw it better. I have my vertebral column right here. Let me draw it bigger 1 second. I'm not the best drawer, so yeah. One last time. Okay, so Okay, I got it. Okay. Inside of this, you have the butterfly-shaped gray matter. So you have the butterfly. 1 second. You have the butterfly-shaped gray matter. I'm going to shade it so that you know this is the gray matter. Okay. Now, why is it called gray matter? Because it contains the cell bodies. Okay. So the cell bodies give it the grayish color, and the surrounding area is white matter because it contains the myelin sheath, which covers the axon of the nerves, giving it faster mobility. Okay, you guys already know this. So in front of this right here, you have anterior and you have posterior. In other words, you have ventral and you have dorsal. How do I differentiate between ventral and dorsal? They might bring it flipped in the exam. You see this kind of groove right here? This is called the anterior median fissure. So this is called anterior median fissure. And this small curvature inwards right here is called the posterior median sulcus. The one on the anterior is called the fissure. The one on the posterior is called the sulcus. Okay? That's how you know which is anterior, which is posterior. Or in other words, which is ventral, which is dorsal. This is really important. Why? Because this is going to depend on how we name everything that we're going to be taking right now. So you see this kind of part right here? This is called the ventral horn. Ventral horn. Basically, all of the cell bodies that are responsible for the ventral activity or the motor activity comes out of this part right here. Okay? What about this part right here? It's called the dorsal horn. So we have ventral horn on the front, dorsal horn on the back. Okay? This part is called the dorsal horn. It contains the cell bodies for the dorsal afferent, okay? Which is basically the sensory. So the spinal nerves are coming out. Okay? Anterior median fissure, posterior median sulcus, dorsal horn, ventral horn. Now the tree, when it grows up, it first begins with a root. Okay? So this is called a root. And this is called a root. Anatomically speaking, this is called the dorsal root, and this is called the ventral root. Okay? Is it clear up till now? So after the dorsal root and the ventral root, what will happen? You have sort of mixing in right here. So basically, the ventral efferent neurons will join in with the dorsal afferent neurons, and the dorsal afferent neurons will join in with the ventral efferent neurons. Okay? I'm going to go over this part really quick again. So we said we have the dorsal root and we have the ventral root. Okay? Now, I'm talking about only the roots. And the dorsal root, what kind of neurons does it have? It has only one type of neuron. Can you guys tell me what neuron it is? Sensory neurons, exactly. So the dorsal roots contains only sensory neurons. So, and examine the OSPE, a person lost complete sensation in his body. Which part, A, B, C, D, E, of the spine is damaged? You're going to tell him the dorsal root. Okay? The ventral root, what kind of neurons does it contain? Motor. Exactly, motor. So if I tell you that a person lost motor control, you're going to tell me it's in the ventral root. Okay? Now, subhanAllah, that if we don't lose complete function of either motor or sensory, there's a mix between the two nerves, between the two neurons. So basically, right here, I have both sensory and motor, and I have both sensory and motor neurons. Okay? What is this part called? The part where it contains both type of neurons? Dorsal ramus. One second, I'm trying to type it. Dorsal ramus and ventral ramus. 1 second. Okay. Why is this important? Because the dorsal ramus contains both sensory and motor. The ventral ramus contains both sensory and motor. Whereas compared to the dorsal root, it contains only sensory. The ventral contains only motor. Okay? So the dorsal ramus will go to the back of the body, and the ventral ramus will supply the front of the body. Okay? Now, another important topic is something right here, a structure right here. Let me just draw it out, and then you guys will tell me what structure is this. Okay. What is this structure right here? Dorsal root ganglia, exactly. So this structure right here is the dorsal root ganglion. Its function is to receive sensory information from the body and send it to the brain through the spine. Okay? Just know that it's called dorsal root ganglia for now. Now, there's another kind of loyal topic, but just so that you guys have everything in the OSPE, inshallah. There's a ramus that's, there's a horn that goes out right here. There's a small horn that goes out right here. Do you guys know what this is called? Lateral, exactly. It's called the lateral horn. Okay? This is sympathetic. Okay? Just know that it's sympathetic. Okay? So, I hope everything was clear. I'm gonna go to the actual picture now that I drew on my iPad, which is better. Okay. So, I'm gonna go over it really quick again. We said we have the butterfly, which is basically the gray matter, and we have the white matter that surrounds it. Why is it gray matter? It's because it contains the cell bodies. And why is it called white matter? Because it contains axons. Okay? Now, how do I know which is posterior and which is anterior? You see this kind of groove, a really big groove inwards? This is called the anterior median fissure, which is basically to the front. So I know that this part of my body is called ventral. And this small wedge inside is called the posterior median sulcus. So I know that this is the dorsal part of my body. So because I know this dorsal, this is ventral, I'm gonna call this horn the dorsal horn, and this horn the ventral horn. Okay? What is the function of the horns? The cell bodies, you see the cell bodies right here, these kind of indexes, come out of the horns. So basically, the ventral efferent, which is the motor efferent, will come out of the ventral horn, and the dorsal afferent, which is sensory, will come out of the dorsal horn. Okay? And then we have another horn, which is on the side. It's lateral horn, sympathetic function. I think that's more than enough for you guys to know. Okay? After that, from the cell bodies, I have the nerves coming outside. Okay? From both sides. The first thing for a tree to grow is the root. So first off, I have the root. So the posterior is dorsal, anterior is ventral. Dorsal root, ventral root. What is the function of these roots? Or why is it, what's the clinical significance? Is that it contains only one type of neuron. Dorsal contains only the sensory, ventral contains only the motor. Now, what will happen later on? You have conversion of both neurons, of both roots, forming a ramus. So, I have the dorsal root, it converged with the ventral root, forming a ramus, plural called ramus. Okay? So, a ramus, ventral ramus, and dorsal ramus. Do you want me to repeat it one more time, or is it clear? I lagged at which part? Repeat? Okay. So Firas got me a mouse, so I can draw better now. Let me just go back to the slides. I'm gonna go over it one more time, but really quick, okay? So I have the vertebral body. 1 second, let me draw it better. I have the vertebral body. And I have the gray matter. Okay? This is the gray matter. I'm gonna shade it. You have the anterior median fissure, the posterior median sulcus. That's how I differentiate between which part is anterior and which part is posterior. So this horn right here is to the back. So it's called the dorsal horn. This horn is to the front. So it's called the ventral horn. Okay. Now, the cell bodies of the ventral horn, or basically, like we said, the ventral efferent is the motor function. So the motor neurons will go out of the ventral horn. Okay. And the sensory will go out of the dorsal horn, creating a root. Okay. So the first part is the root. This is called the dorsal root, and this is called the ventral root, posterior and anterior. Okay. Why is it important? Because it contains only one type of a neuron. And we said same Dave. So S for D, so basically the dorsal is sensory. And then we said the same Dave, the M and V, the motor is for the ventral. So this part contains sensory, this part contains motor neuron. Okay, subhanallah, so that you don't lose both functions if you have an injury. These neurons will converge. Wait, I drew it a bit too long. These neurons will converge. Forming what is called a ramus. So this right here is called the dorsal ramus. This is called the ventral ramus. Why is this important? It contains both type of neurons, both sensory and motor. Now, before the conversion occurs, you have something called a ganglia. And this ganglia is on the dorsal part, and it's on the root. So what will we call it? The dorsal root ganglia. Dorsal root ganglia. Okay? Is ramus also called rami? Yeah, so rami is the plural of one ramus. So one is ramus, plural is rami. You're welcome. Is it clear? Okay. So I've got the actual picture that might actually come in your exam. They're not going to break my drawing, obviously, because it's not that good. So they might ask you, name the structure, or they might ask you, a person had an injury to this part right here. What kind of neurons will he lose? He's going to lose sensory sensation or sensory neurons. He might ask you if he lost sensation right here where they converge. What will he lose? He will lose both. Okay. He might ask you if there's an injury. Wait, let me clear it all. He might ask you if there's an injury here on the ramus. What type of sensation will he lose? Nothing. Why? Because you still have this part right here. It converges to both. Okay. It might, but it's not lost. Okay. Is that point clear? Oh, that's for us. Okay. Okay, so let's try to see an OSPE question. Okay. Can you repeat? Yeah, I'll repeat. Okay. One more time. 1 second. One more time. So different types of injuries. Let's say I have an injury to this part right here, which is the dorsal root. What type of sensation will he lose? We said same, Dave. He's going to lose sensory sensation. Yeah. What about this part right here? He's going to lose motor function or motor sensation. Okay. However, what about if he loses, or if the nerve is cut right here? He's going to lose both sensory and motor. Now I have a question. What about this part right here? If I cut it off, what will happen? Answer me in the chat. If I cut this part right here, will he lose anything? What will he lose? Will he lose nothing? Nothing. Exactly. So he's not going to lose anything because I still have the dorsal ramus, which contains both motor and sensory. Okay? Is it clear? Where? Okay, I'm going to draw it again. You see this part right here at either one of the ramus. If I cut it off, I have the other one to take over for it. Okay? But I'm going to have a weaker sensation from the front of my body, kind of, okay? Because it's the ventral. Okay? Yeah, nothing really happens, just weakness. So, yeah. Okay. I want you all to answer in the chat. What is A? What is B? What is C? D, E, F, and G. Write it in one message. Don't spam the chat, okay? I don't want to read everyone. Do we have to know the column? What do you mean? You mean the vertebra? I'm not sure. I don't think so. It's basically the same for all. You mean like what type of vertebra is this? I don't think so, no. They're not going to ask that.
Okay, different answers.
A is the ventral horn. C is the lateral horn. B is the dorsal horn. Okay, why did you say that? I want someone to answer me. Why is this the ventral horn and this the dorsal horn? How did you know? Exactly. So the anterior medial fissure is the one that tells you which is anterior and which is posterior. That's how this question gets in the exam. It's kind of tricky. We're going to flip it around for you so that you guys get confused. I mean lateral column in the previous slide. Lateral column. Not really. As long as you know that there's the lateral horn, they're not going to ask you about the lateral column, you know?
The only thing they're gonna ask on this.
Exactly.
This
So they're
is the
going to tell
most
you,
common one. Just know the ventral horn, lateral horn, dorsal, and what happens if you cut the tendon. That's it. Like, what about D, E, F? Why didn't you get an answer?
Wait, just come on. D ventral
Zero?
root, E dorsal root, G spinal nerve, F dorsal ganglion. MashaAllah. Perfect answer. Okay. So I'm going to ask the question I asked before right here. I have a cut right here. What will happen? This is the type of question that gets asked in the exam. Exactly. Great answer, inshallah. Ventral horn, dorsal, lateral, ventral. Yes, exactly. Now, what type of sensation will I lose if I cut this nerve from right here? Motor, motor, motor. Why are you guys saying motor? Because this is the ventral root. Yeah. You might get confused because we just took the example before that this is the ventral, but in this example, this is the ventral. So you're going to lose motor function. Yeah. Another way the question might be asked. A person lost complete sensation. Again, complete sensation. In which structure, A, B, C, D, E, F, G, is the nerve cut? He still has motor function. He only lost sensory sensation or sensory function. E, F, E, F, E, both work. Okay. So basically, it's going to be a double queued answer. So basically, E and F will both count correct. Okay. Point clear. Where is the ramus in this structure? It's not shown. So basically, it's like converged right here, kind of. So basically, it does not show the difference between the two. Clear, clear, clear. You can see it kind of right here. You see it, the one at the back. But they're not going to ask about it here. Okay. Clear. Okay. Can you repeat the point where you cut off, nothing happens, please? Okay. So basically, it's not shown in this picture right here. Let's take this picture right here. Okay. Let's say that I cut off the nerve from right here. Because the dorsal ramus has both motor and sensory, you're going to lose some motor and some sensory function from your anterior part of your body. But you're not going to lose it completely. Okay? So basically, the patient will not lose motor function and he will not lose sensory function. He will only get damage. Okay? Because there's another part that contains both. So is that clear now? Okay? Okay. So we're done with the vertebra, we're done with the bones, and we're done with the muscles. Now we're going to go into the joints. So first off, we have the fibrous joints. They are tough fibrous tissue that hold the bones together. So an example is sutures, which is the kind of fibrous joint that's found in the brain, not the brain, sorry, in the skull. The syndesmosis, which is basically between the ulna and the radial. So you see the two bones that are in your arm. They're held together by fibrous joint. And the gum fosses. So from the word gum fosses, gum in your teeth. So it basically holds the tooth inwards. Okay. So 3 examples, pure memorization. sutures, syndesmoses, gomphoses are fibrous joints. Cartilaginous joints, there are two types, and this was an objective in your lab, so you need to know the difference between the two. You have the primary and secondary cartilaginous joints. The primary is called synchondroses, and the secondary is called symphysis. So, synchondroses are bones that are connected by hyaline cartilage. Hyaline cartilage, okay? They are immovable. What is an example that you guys took before? You know how the long bone has diaphysis and epiphysis? So basically, the diaphysis and epiphysis of a growing long bone, okay? They are held together by hyaline plate or hyaline cartilage, okay? Symphysis, from its name, the bones are united by a layer of fibrocartilage, which is slightly movable. The easiest example, symphysis, pubic symphysis, okay? The pubic symphysis is right here. It's right in the anterior pelvic area. It connects the two pelvises together, okay? And another type is the intervertebral joints. So basically, you see this kind of whitish color between the two joints, between the two vertebrae. This is an example of the symphysis joint. So cartilaginous, primary, secondary. Primary is called synchondroses. Secondary is called symphysis. Synchondroses bones are connected by hyaline cartilage, and they're totally immovable. Example, diaphysis and epiphysis of a growing bone. Symphysis or secondary, they are bones that are united by a layer of fibrocartilage and they're slightly movable. Example is pubic symphysis and between the joints between the vertebral bodies. Okay, again, pure memorization. I hope just I made the concept clear. Okay, moving on. Synovial joint. Now the synovial joints, they're found pretty much everywhere in the body, and it's there are many examples. So don't get confused. Don't get confused with this. Okay. This is called a synovial ball and socket joint, synovial pivot joint, synovial saddle joint. So the name of the joint itself is ball and socket. The type of joint is synovial. Know the difference between the two, okay? Definition of synovial joint is the presence of fluid-filled cavity. So the ones before, we had no fluid-filled cavities. If you look, one second. If you look at these, there is no cavity at all, okay? Whereas in the synovial, there's a sort of fluid cavity. It reduces friction. We're not going to go into it for now, okay? The first type, ball and socket, it basically gives you a free range of motion. I can go everywhere I want, okay? Wherever I want to move my arm, I can move it. Ball and socket, example is the shoulder region or the shoulder joint. Pivot is an example between the ulna and the radius. If you look at, where is it? One second. Ulna and radius. It's not shown here, but it's shown the neck, okay? So the ulna and the radius, which are the two bones right here, when I twist my arm this way or this way, the bone is moving around it, okay? So I have two bones. One of the bones are moving around the other, okay? So it's the same thing with the neck. When I'm moving around, one bone is moving around the other, okay? So that's the definition of the pivot joint. For the saddle, you know the saddle that you put on the horse to ride the horse? It's basically the same thing. So if you look at this joint right here, it's kind of like a saddle shape. And where do you find this? You find this between the thumb and the joint of the thumb. Now, you need to know what it's actually called. It's called the first metacarpophalangeal joint. We said the metacarpal is the first long bone or the miniature long bone. Phalange is the first bone in your finger. So in the past, they got a question about this. You need to name this type of joint. You're not gonna say thumb joint. You're gonna say first metacarpophalangeal joint as an example of a saddle joint. Okay. For the plane joints, they're basically just plane. They move on each other. They're between the carpals or the tarsals. So you know the bones that we talked about, the short bones that are right here. Between them, I have a plane synovial joint. So basically, they kind of have really little of motion, but they have a joint between them. Okay. Hinge joint is the one in the elbow. It's one uniaxial, so it goes in one direction, flexion and extension. Okay. And the condyloid. Condyloid is between the radial and the carpal bones. So basically, we said we have the radial and ulna in your arm. Between the radial and the carpal bones, you have a condyloid joint. Okay? And between the metacarpophalangeal. So basically, you see your knuckles. Between the metacarpal and the phalange, you have a condyloid joint. We said the first metacarpal we said we have the first metacarpal and the phalanx, the first phalanx. Between them, we have a saddle joint, whereas all the other fingers, between the metacarpal and the phalanx, we have a condyloid joint. Okay? Is that clear, or do you want me to repeat it one more time? Yeah, you're actually right. Okay, wait 1 second. So for the thumb, it's not called metacarpophalangeal. It's called carpometacarpal. Okay? So thank you for whoever fixed my mistake. So it's a saddle joint nonetheless, but it's called carpometacarpal. Okay? Remember it. Carpometacarpal. Okay? Whoever fixed my mistake, thank you very much. Can you repeat cartilage joints, please? Okay. So cartilage joints, we have two types, the primary and the secondary. Okay? For the primary, it's called synchondrosis. For the secondary, it's called symphysis. Synchondrosis has no motion; it's immovable, and it's connecting bones by a hyaline cartilage. So the difference between the two, hyaline cartilage, symphysis is fibrocartilage, and it's slightly movable, whereas the synchondrosis is not movable at all. Okay. So synchondrosis is the primary cartilage. It's connecting two bones by hyaline cartilage, example diaphysis and epiphysis. Symphysis is the secondary cartilage. It's made up of fibrocartilage and it's slightly movable. Two examples, pubic symphysis and the joints between the vertebrae. Is that kind of clear now? How do you know whether the answer for the example ball and socket or synovial? Let me check what you mean. Ball and socket or synovial?
You said both.
So basically, ball and socket is a type of synovial joint. So all of these are synovial joints, but they have a specific function. So basically, it's called a synovial ball and socket joint. This is called a synovial pivot joint. This is called a synovial saddle. They're always okay. So sorry about that. The speaker suddenly went crazy. Okay, so again, they're all called synovial joints. They're all called synovial joints, but they're specific. Ball and socket, synovial pivot, synovial saddle. Yeah. Can you repeat the carpal metacarpal? Okay, so the thumb is a type of carpal metacarpal joint. Okay, so it's a type of saddle joint. Then the specific name for it is the carpal metacarpal. Okay. Okay, guys, is the sound bad only for me? So if they ask us what type of joint is this, do we say synovial or do we have to be more specific? You need to be more specific.
Yes,
So basically, if they show you the shoulder area, you're gonna say synovial ball and socket. You can't say only synovial. Yeah.
then you stay on the safe side. Say everything.
Yeah. So basically, be specific. Okay, and don't be specific. You want me to repeat anything one more time? Sorry about the inconvenience for the speaker. You're welcome. Okay. We're gonna go to the types of joint movement. Yeah. I'm gonna go over this really quick. I don't think they're gonna ask you about this, but again, for the sake of having everything covered, we're gonna talk about it. Okay, flexion, extension, outwards. So flexion towards where I'm pulling. So my biceps is pulling my upper arm towards it. Extension is opposite to the line of pull. So the biceps is pulling this way. That's called flexion. The bicep is pulling out. It's not pulling. It's called extension. The opposite to the line of pull. Yeah. Abduction and adduction. Abduction is moving upwards. Abduction. Adduction is moving inward. So an easy way to memorize this is adding adduction. So I'm adding my arm to my body. So adduction moving closer, abduction moving outwards. Okay. Rotation is just simple. It's like rotating your neck. Circumduction, from the word circle. Circumduction is moving your entire arm like around. Okay. And then you have pronation and supination. Pronation means I'm moving my palm downwards. Supination, I'm moving my palm upwards. An easy way to remember this is subhanallah. Okay? So when you're saying subhanallah, you're making dua, subhanallah, your palm is upwards. Pronation is the opposite way. Okay? You're gonna get used to these mnemonics, trust me. Opposition, moving against each other. So basically the thumb and my pinky are moving against each other. That's called opposition. Inversion, inwards. So I'm moving my hand inwards. Eversion, outwards. And that's it for that part. Do you guys have any questions, or do you want me to go over that again? Okay. So we'll go into the cardiovascular block. Yeah, cardiovascular part. So again, one of my nice drawings. So let me just do something really quick. Okay, should be good. Okay. So first off, let's start with the arteries. Yeah, I'm gonna go over this really quick. You have the heart. From the left ventricle, you have something going out. The biggest artery in your body. What is that called? Wait, let me draw it on the iPad because it's much better.
Try to do it.
Okay. So we have the heart. From the left ventricle, I have the biggest artery in my body going out of it. What is this artery called? I want quick answer there, quick fire. Okay, aorta, nice. What is this part of the aorta called? Ascending aorta, exactly. So this is the ascending aorta. What about this part? Arch of aorta. What about this part? Descending aorta. Exactly. Okay. So 3 parts of the aorta: ascending, arch, and descending. Okay. Let me just erase that really quick. So from the aorta, I have 3 main trunks going out of it. One going to the right side of my body. Again, remember, this is the right and this is the left. One going upwards and one going to the left side of my body. What is this one right here called? Brachiocephalic trunk, exactly. Brachiocephalic trunk. Now, it's important to know, in the arteries, I have 1 brachiocephalic trunk. In the veins, I have 2. We're going to talk about the veins in the veins part. But for the artery, why do you think we only have 1 brachiocephalic artery or brachiocephalic trunk?
That's maybe
farther from the aorta. Exactly, mashallah. So because the aorta is on the really to the left, it's like really to the left, I need 1 big artery that brings my blood to the right side before dividing. So that's the function of the brachiocephalic. Yeah. So the aorta is is more to the left than to the right. So I need 1 big artery to bring my blood to the right side. Okay. What about this artery right here? What is it called? Left common carotid. Exactly. What about this one right here? Left subclavian. Exactly. Now, the brachiocephalic trunk will then divide into something that's going upward towards my head and something that's going downwards towards my arm. What is this one right here called? Right common carotid. Right common carotid. What about this one? Subclavian. Exactly. So this is right subclavian. Okay. Is the arteries clear? Is it clear so far? Do you want to repeat any point? Clear. Okay. So let me just erase this part really quick. Okay, so we said that this is the descending aorta, right? Descending aorta. The descending aorta is further divided. Let's say that this is my chest region. Let me change the color. 1 second. 1 second. Let me change the color. Okay. Let's say this is my chest region. And this is my abdomen region. What is this aorta called? Right here. The descending aorta that's in the thorax, thoracic region or chest region. It's called thoracic aorta. Okay. What about the one in the abdomen? It's called abdominal aorta. Okay. It's just really important to know it was in the objectives. So the descending aorta, the part in the chest called thoracic aorta, the part in the abdomen called abdominal aorta. Okay. Now, we're done with the chest area of the aorta. We're going to go to the lower limbs now. Okay. Can you repeat the part of common? What do you mean common? No, you're not bothering at all. Can you repeat, please? Okay, I'll repeat it one more time. So you have the heart, you have the aorta coming out, you have the ascending aorta, you have the arch, you have the descending. From the aorta, you have brachiocephalic trunk, you have left common carotid going to the head, and you have the left subclavian. Brachiocephalic trunk is further divided into right common carotid, right subclavian. Is that part clear? So I have the left common carotid coming directly from the aorta, going to my head, and the right common carotid coming from the brachiocephalic trunk, going to my head. Okay? So that's why when you're taking blood pressure, you don't compress both at the same time, because that's the only blood supply to the brain. Okay? Clear for now? Descending aorta. In the thorax or the chest, it's called thoracic aorta. And then in the abdomen, it's called abdominal aorta. Is the brachiocephalic trunk part of the ascending aorta or the arch? I'm not entirely sure. Let me just check really quick. 1 second. Brachiocephalic trunk. It's part of the arch. Okay, so all three of these branches are coming out of the arch. Okay, is that part clear? So here's the original drawing. I just added the coronary artery because I think I saw it in the objectives as well. So the coronary artery is the artery that supplies the heart. Okay, so is this part clear? We're gonna go to the lower extremities now. Yes, yes, yes. Okay. Going back to the drawing. Let me just erase everything really quick.
Just open your new slide.
That page. Yeah. 1 second. More refresh.
There you go. Let's go next. And
Previous.
nine.
Okay. So we're gonna go to the lower extremities part. We said we have the abdominal aorta. It's loading, I think. It's kind of laggy. 1 second, let it load.
No, it goes back.
Okay, I'll just do it on my laptop. Okay, so We said we have the abdominal aorta. Abdominal aorta. The abdominal aorta is then divided further into two branches. Can you guys tell me what the name of these branches are? Quick fire. The abdominal aorta is divided into two branches, left common iliac, right common iliac. Exactly. So this is the right common iliac. This is the left common iliac. Okay. So the first branch that comes out of the aorta is called common. Okay. Why is it called common? Because after it, we're gonna have two branches. What are these two branches right here called? Exactly. So internal iliac, left and right, and then the right external iliac and the left external iliac. Okay. So abdominal aorta divides into left common iliac and right common iliac. Okay. The first branch is called common. So right common iliac, left common iliac. The common iliacs are then divided into internal and external iliacs, left and right respectively. Okay. After that, the external iliac will become the femoral artery. I think that's what the doctor told you to memorize for now, right? Common, left and right common iliac. No. So you have abdominal aorta, then common iliac, left and right, then right and left external and internal. So there's no common and then left and right common. No, it's right and left common and then internal and external. Yeah. So let me show you guys the picture really quick. So abdominal aorta divides into left common and right common immediately. So abdominal and then common. After this, you have the external and the internal iliacs, and then the external will become the femoral. Okay. So let's move on to the veins. Yeah. I'm not gonna draw because I took a lot of time, so I'm just gonna go over this on the drawing itself. So for the veins, yeah, we're not gonna start from here. We're not gonna start from the heart. We're gonna start from the body because the blood is draining from the body going to the heart. Whereas in the arteries, we were going from the heart to the body. Yeah, so that's the difference between the veins and the arteries. Yeah. But for the sake of simplicity, we're just gonna go from the heart itself. So you have the superior vena cava, which drains the upper part of the body. You have the inferior vena cava, which drains the lower part of the body. Okay. So what drains into the superior vena cava? Right and left brachiocephalic vein. Remember how I told you in the arteries, it was only the right brachiocephalic artery or brachiocephalic trunk. Here it's both right and left brachiocephalic veins. Okay. From the right brachiocephalic vein, you have the left internal and the right, yes. So you have the right internal and right external jugulars draining into it. And in the left, you have the left external and left internal jugular. So the difference between arteries and veins. Artery is called carotid artery. Veins is called jugular vein. Okay? The jugular vein drains the brain. The carotid artery supplies the brain. They're different names, but they supply the same part and drain the same part. Okay? After that, the brachiocephalic will then become this left subclavian vein, just like the artery. So left subclavian vein will become left brachiocephalic vein. Left brachiocephalic vein receives blood from the left external and the left internal jugular. The left brachiocephalic vein joins the right brachiocephalic to form the superior vena cava, and it will enter into the right atrium. And if you guys remember, I'm not going to go over this because I don't have much time. Right atrium, then right ventricle, then left atrium, then left ventricle. And remember, the left ventricle is thicker because it pumps blood to the entire body. Okay, just memorize this really quick. Like go over it quickly before the OSPE. Okay, is this part clear? Is the drainage of the upper extremity clear? Do we need to further identify the mesenteric arteries coming from the abdominal aorta, or just labeling the abdominal aorta is enough? I think that abdominal aorta is more than enough. Mesenteric, you're gonna take it to virtual blocks, I think. For now, just remember abdominal aorta. Okay? Because if I'm not mistaken, the doctor has told you in the lab to just remember up until here. Can you give us like a sample question on these questions? Okay. How might a question come here? mostly just identify the structure, like most of the part. Like if you're gonna get a pin, let's say the pin is pointing here. They're gonna tell you what structure is this, and what part of the body does it drain. Upper extremity is called the superior vena cava. Like that's the type of question that might come here.
You know those models in dry lab where it's like the entire circularity? They could just put a pin, for example, here or maybe on one of them, and they're going to like label this structure and what kind of oxygenated blood does it carry. And they can do this with everything, like not just veins, arteries as well. So like over here,
So
I think they
mostly,
will do it with arteries now. So like this is most probably also, and with the arch of the aorta, this could come in. Maybe they put a label, like a pen on the left common carotid or the right common carotid or the brachiosphax. So just like be very familiar with the structure, and it's gonna be clear. Hopefully, okay? It's gonna be a picture because the OSPE is online. It's not gonna be.
and remember that the first branch is the brachiocephalic trunk, the
Yeah.
second one is the left common carotid, the third is the left facade.
And always orient yourself. Know which way is left and right because that's where the
Mistakes happen.
yeah, that's where they play with the question.
Yeah. So upper extremity is clear. So the brachiocephalic has the subclavian and jugular drain into it. Yes. So the subclavian will become the brachiocephalic, and the external and internal jugulars will drain into the brachiocephalic. Okay, exactly. So we're gonna go to the lower part, just the same exact naming as the arteries. Okay, that's what's nice about arteries and veins. Arteries and veins that run together have the same name. Okay, IVC, inferior vena cava, become left common iliac, right common iliac. After that, the iliacs will divide into internal and external, and the external will become the femoral. Okay, just like the arteries, the veins are named the exact same thing. Here, okay. So moving on, let's look at the lymphatic system. So I'm not gonna go into details about the lymphatic system. I'm just gonna go give you a quick overview about it. So the lymphatic system basically drains the fluids that leak from the cell and bring it back to the blood. Okay. So there's something called the extracellular fluid. I think you took it in the ECF, ICF lecture that Khalid did a pile on. So basically, fluids that leak from the cell are taken up by the lymphatics and they're taken back to the blood. Okay. Now, what's really two important topics that you need to know? The first one, the upper right part of my body, meaning my right side of the head, right side of the chest, and right arm, drain into the right lymphatic duct. All my entire other body will drain into the thoracic duct. Okay, it's a really important topic that you need to know. Right arm, right chest, right head, so basically right side, right lymphatic duct. All the other parts of my body, thoracic duct. Now, an important lymphatic duct that you need to remember is the cisterna chyli.
You said I could roll though. Yeah, I thought you were smart. Physical.
I think that was a mistake. Okay. So an important lymphatic duct that you need to know is the cisterna chyli. Yeah. So the cisterna chyli is a lymphatic sac that receives lymph from the abdomen and lower half of the body. So basically, it's like a checkpoint, basically. Okay. So if you look at this lymphatic duct right here, it's found between L1 and L2. Remember the position. Okay. I think we got a question about this before. So the cisterna chyli found between L1 and L2. And what part of the body does it drain? It drains the abdomen and lower half of the body. So basically the abdomen and my lower legs, lower extremities. And then after this, cisterna chyli will drain into the thoracic duct. Okay? So basically it's like a checkpoint or a midpoint. I have an off-topic question. To be honest, I really didn't understand how the OSPE is performed. Some say it's online, some say it's in PHA. Can you please like outline? Okay, so I'm just gonna go over this really quick. Okay, so the OSPE, you're gonna be in PHA. You have your device, iPad, laptop, I don't know which device you're going to use. And then you're going to have like the TBL. Okay, so your TBL, you give you a code and then you enter. You're going to give you a code and then you're going to enter the OSPE. They have a picture and then they have two parts, A and B. They're going to ask you either what is this? Name is function. What happens if this is cut off? Can you name the structure? Where do you find it? Something like that, okay? So it's online, meaning that it's on your device. You're not going to do it from home. You're going to be in the PHA using your device for the OSPE, okay? You're welcome. So is the lymphatic system clear? We're going to go a bit more over it in the histology part, but for now, is this part clear? the right part, right lymphatic duct, other part of the body, thoracic duct, and the sternochyli, abdomen, and lower extremities. Okay. So we're gonna start off with histology. So we're done with the anatomy for now. We're gonna go into histology. So first off, we have the epithelium. Okay. The epithelium basically it covers most of our body structures. It's basically the outermost covering. Okay. Classification based on the number of cells. We have two main classifications and a third one. Okay. You have the simple, meaning that we have a single cell layer. Stratified, meaning that we have more than one layer. Pseudo-stratified means that it's fixed stratification. So it's not stratified. It just looks like it's stratified. Okay. So first off, let's look at the simple. Simple means it's only one layer. So if you look at this structure right here, you have one layer of cells. What do I mean by one layer? One layer looks like this. Multiple layers look something like this. Okay. So one layer of cells is called simple. Multiple layers is called stratified. Okay. So is that clear on how we name them on the number of cells? For the classification based on the shape, we have three types. We have the squamous, which is like flattened out. We have the cuboidal, which is cube shaped from its name, cuboidal, cubed. Columnar, which is like a column, it's really long. Okay. Squamous, if you look at it right here, it's really flattened out. It's really thin. So I'm gonna try to zoom in onto this image right here. You see how the cells are flattened on the surface? They're really flat. Okay. Whereas in the cuboidal, they're equally wide as they are long. So they're shaped like a cube, equally wide as they are long. Let's look at this. You see how they're almost equal, like it's shaped like a cube? That's called cuboidal. And in this case, it's simple because it's only one cell layer. Okay. For the columnar, it's longer than it is long. So if you look at this right here, it looks like a column. Okay, like what's it called? A traffic light. It's really long. Okay. Is it clear for now? So when we join the two names together, if it's a single layer, simple cuboidal, simple squamous, simple columnar. If it's stratified, stratified cuboidal, stratified squamous, stratified columnar. Okay. Now for the pseudo-stratified, we just talked about this simple single cell layer of flattened cells, location in the blood vessels. For the cuboidal, they are tube shaped, found in the kidneys. For the columnar, they are longer than they are wide, found in the stomach. And then you have the pseudo-stratified columnar epithelium. Why is it called pseudo-stratified? Because it's fake stratified. So the word pseudo means fake. So pseudo-stratified means that it's fake stratified. It appears stratified. All of the cells, you see right here, rest on the basal membrane, which is this one right here. But some do not reach the free surface. What does that mean? I have the basement membrane right here, and I have the pseudo-stratified columnar. They're supposed to look something like this. However, because the cells are really intact and really intact together, they're really close together, some of the cell bodies will hit the other cell body, and it will stop right here. So it will not go to the bottom. It will not go to the basal membrane. So it will appear stratified, but it's not stratified. Okay? Is that point kind of clear now? I hope I did not confuse you even more. Okay, clear, yes, okay, thank you. So where do you find the pseudo-stratified? In the respiratory tract. Okay. Now, you have something called transitional epithelium or urothelium. Urothelium. Okay. Now, where do you find this? In the urinary bladder. And how do you know that this is a transitional epithelium? Because it has special types of cell on the surface, known as umbrella cells. You know how the umbrella is shaped something like this? Look at these cells right here. They're shaped like this as well. You see how long they are? They're shaped like umbrellas. You see that? So if you see umbrella cells on the top or on the surface, this is a transitional epithelium, or in other words, urothelium. And where do you find it? In the urinary bladder. Okay, so we're gonna call epithelium right now. Okay. Can you please repeat the last slide? You mean the transitional epithelium? Okay. So transitional epithelium, basically, one second. Okay. Transitional epithelium is a type of epithelium that has umbrella cells on the surface. Put it in really simple terms, Umbrella cells on the surface, urothelium. U for you. Umbrella cells, urothelium. How do I know that there's umbrella cells? You see how it's kind of going out, then going in, going out, then in. And you see how the cell kind of goes inwards like this? Like the shape of the umbrella. An umbrella looks something like this. Okay? Inshallah, it's more clear now. Is it clear? Yes? Okay. So moving on, we're going to go into the structures that are found on the epithelium. First off, we have cilia. Okay. So what is cilia? They are short eyelash like filament. So you know your eyelashes, they're really thin and they're found in a large number. They are found in numerous and on tissue cells. What is their function? So you see this right here. This is the cilia. What is their function? They move molecules on the surface. So basically, I have nutrients. Yeah, I have a lot of nutrients. So let's say I have a large amount of nutrients here, and they're not all getting absorbed. So the cilia will move them along that I have more absorption of the nutrients. Okay. So the function of cilia is movement, not movement of the cell, movement of the molecules outside, and they're found in numerous numbers. Where do you find them? On the epithelium. What is an example of this? Pseudostratified ciliated columnar epithelium. So first off, we put the number of cells, simple, so, stratified, pseudostratified, and then we put the function, the structures it has. Does it have cilia? Does it have keratinized? We're gonna put that as the second name. So first off, number, structure, then shape, and then epithelium. So in this case, we have pseudo-stratified. It's not stratified, it's not simple. It's pseudo-stratified because they're all trying to compete to go into the basement membrane, but they're blocking each other. Okay, so that's why it's pseudo-stratified. What about the structure? It has cilia. So pseudo-stratified, ciliated. What about the shape? It's columnar. Pseudo-stratified, ciliated, columnar epithelium. Do we understand how the naming works now? You're welcome. Okay. Another structure or functional structure about the epithelium is keratin. So keratin is found on the outside surface of the epithelium. What does it do? It's a layer of anucleate cells. So basically, it does not have a nucleus at the surface of stratified squamous epithelium. So on the surface of stratified squamous epithelium, I have keratin. In the case of keratin, I'm going to put it before the number of cells. Whereas cilia, microvilli, everything else, we're going to put it after. So it's found on the stratified squamous epithelium. What would we call it? Keratinized, stratified squamous epithelium. What is its function? It's basically like a protective layer. Where do you find it? On the skin. So the skin is made up of keratinized, stratified squamous epithelium. Is it clear? Do you want to repeat anything? Thank you. Okay. I think yes. So I know you guys got bored of me, but Firas will take over from now. So inshallah, he will help you guys out.
All right. Okay, can you guys hear me? Let's see. Can you guys hear me? Thank you, Adam. Okay. So do you guys want like a 5-minute break? Or maybe a 3-minute break so we don't spend a lot of time here? No. Okay, let's just jump straight into it then. Yalla. So, as our friend Adam have concluded epithelium, now we're going to move over to connective tissue. So to start off, connective tissue, if you guys remember, it's basically made out of 3 things, right? It's made out of extracellular matrix, fibers, and cells. And the way we classify it, like it depends. Maybe it's regular, whatever. So let's just go over each individual like connective tissue and just the characteristics and how you can identify them. So we start off with the reticular fibers, and we can call this reticular connective tissue. So the basically like the most characteristic feature here is the cherry blossom-like appearance. Like you can guys see the reticular fibers and then like all of the cells around it. It looks like a cherry blossom. And these black things are the reticular fibers. They're made out of collagen type 3. Let me see if I can draw. You guys can see. So these fibers, they form this meshwork that will hold up the organ. Now we can find this in lymphatic / hematopoietic organ. And there's a lot of space here, basically a lot of cells, hormones, and so much things is going on inside these organs. That's why we need this reticular like meshwork and this like a lot of spaces. Now let's move on to another type of fibers, which is elastic fibers. We can still see like these long black or like purplish fibers. And you may be wondering, how can I like distinguish them from reticular fibers? You guys can see how like it's more dense, right? Over here we have a lot of spaces and it's very distinguished, okay? Meanwhile, elastic fibers, they're all also more so parallel with each other. They're more regular and they're like a little bit more dense, ماشي? And they're made out of elastin fibers to be able to withstand regular stretching. That's why they are all going in the same direction. And we find this essentially in blood vessels. So the blood vessel with the most like, let's say elastin, like the biggest elastin fiber would be the aorta to be able to withstand a lot of pressure, right? So it's gonna be like the thickest, like a lot of fibers will be in there, okay? Now we're gonna move on to dense irregular connective tissue. Why is it called dense irregular? Number one, let's like break up the name. We have dense and irregular. It's called dense because there isn't a lot of white spaces or like in general extracellular matrix. It has little extracellular matrix and ground substance, and it's just filled with collagen fibers and a lot of stuff, but it's irregular because there's no orientation. If we compare it with dense regular, as you can see, there is orientation, like they're all going synergic, like in the same, oh, I didn't change the slide. Okay, they're all going in the same direction. So this is dense regular. As you can see, it's like dense. There isn't any space in between. It's all like compact on top of each other. And over here, it is compact, but it's irregular because it's going all over the place. Now, where would we need this? In places that moves a lot and can be able to withstand the friction and whatnot. So for dense irregular, we would find this in the deep dermis of the skin. You guys can pull your skin in all directions and not feel any kind of pain, right? But when we're talking about dense regular connective tissue, all of them are going in the same direction. That's why they can withstand a lot of force that's going in one direction. And that is helpful, such as in like tendons and ligaments and whatnot, muscles basically. And lastly, like let's just go over this real quickly last. So collagen fibers with no definite orientation, and dense regular connective tissue is like mainly composed out of type 1 collagen, okay? Then we have loose connective tissue. So we said dense regular, dense irregular. Now we're talking loose connective tissue. There's no loose regular or irregular, it doesn't matter because it's just loose. And the major point here is that there's a lot of extracellular matrix and ground substance. And we can even see blood vessels and like still we can also see the collagen fibers. So you can guys, this like, where am I going? How can I see the chat? Hold on, let me figure this out. Maybe you guys are asking questions and I'm not. Okay, no one is asking any questions. Is everyone okay? Okay, tamam. Let's carry on then. I'll just keep the chat somewhere so I can see it. Okay. So in loose connective tissue, there's a lot of spaces in between the fibers and whatnot. And it's more so like extracellular matrix and ground substance, meaning that it can withstand forces and friction and whatnot. So we find this under the epithelial lining of almost everything, such as like hollow organs and like a lot of organs, okay? If they ask you, where would you find this for now? Just say under the epithelial lining. You don't have to specify exactly where. So over here, I think this slide is the mammary gland. You don't need to think that, but just if they ask you the location of loose connective tissue, under the epithelial lining, okay? Now we go into the embryonic connective tissue. And we have two types. We have mucous embryonic connective tissue and mesenchymal. Let's start off with the mesenchymal embryonic connective tissue. And like the feature that identifies it is these spindle-shaped cells. And they are found, like this kind of connective tissue is found in the embryo and umbilical cord.
Now, if we want to compare it with the mucous embryonic connective tissue, we can still see those spindle-like cells, but this is only found in the umbilical cord. And like there's a lot of more like space, or like it feels more fluid, right? Over here, it feels more so dense, like there isn't a lot of space. Meanwhile, when we look at this, there's like, it feels like it's a jelly. And that's what we call it, Wharton's jelly extracellular matrix, alongside these spindle-like shaped cells. So how will the OSPE like tackle this? How will any of these questions come? They will basically give you this photo, and they're gonna ask you, let me just clear this. They're gonna ask you, what are you looking at? And you're gonna have to tell them, oh, this is reticular fibers. And maybe they will ask you the location of it. So you're gonna tell them we can find this in the bone marrow, in the spleen, in lymphatic nodes. And maybe they're gonna ask you about the function of them. So in elastic fibers, they're gonna maybe ask you why is it designed this way? So you tell them it's to withstand regular stretching in blood vessels. Okay, all clear about how like maybe possibly OSPE questions can come? They're not going to specifically like ask about cells here. Although like you can always say, oh, we can see fibroblasts, macrophages and whatnot. But always say collagen fibers, ماشي? Let's move on. Now we're done with connective tissue. We're gonna start muscles. So muscles, like it's pretty straightforward. We just have 3 types of muscles. But we have a question. Can you please repeat the collagen fibers part? Do you mean in like in general, or just like connective tissue? There's always going to be collagen fibers, and what makes these collagen fibers are the fibroblasts. Like if they ask you, yeah, exactly. If they ask you, for example, what characteristic features, like what are the characteristic features of this connective tissue, you can say collagen fibers, and some you have to specify which collagen fiber. So this like reticular fibers is collagen type 3. Dense regular is collagen type 1. So be careful and just know exactly what the characteristic features of each single connective tissue. Let's move on to the muscles. So as we were saying, we have 3 muscle types. We have skeletal muscle, cardiac muscle, and smooth muscle. And they're all, inshallah, very straightforward. Over here, we are seeing a skeletal muscle slide. And the characteristic features of skeletal muscle is the striations that you guys can see. Can you guys make out these lines that are like, in 1 second? These lines that are like going hick. You guys can see them, right? We call these striations. They're like zebra lines, and they go over the entire cell. This thing is an entire cell. This is a myocyte, and it's a very long cell, and it's also unique with the fact that it has more than 1 nucleus. It's multi-nucleated, okay? So we have striations, multi-nucleated, and the nuclei are not inside the cell. So imagine this is the myocyte. I hope you guys can see me. This is the myocyte. The nucleus would be on the outside, like on the edges, on the periphery. They would not be in like the center of the cell or inside. Over here, you guys can see like there's a nucleus clearly on the inside. Well, it's a trick question. It's now on the inside. This is just a histology slide that has been cut exactly over the nucleus. So it seems as if it's in the center and inside the cell, but in reality, it's just on the periphery. Okay, everyone got that? And the location is just skeletal voluntary muscles everywhere. This is a longitudinal section, exactly. Over here, we have smooth muscle. Now, smooth muscle, it's kind of the same story, but there are no striations at all. You guys cannot see a single striation, right? Meanwhile, if we go back here, we can see many striations. So when you don't see striations, this is smooth muscle. And it's also mononucleated myocytes. So it doesn't, like each cell has 1 nucleus. It doesn't have 3, 4, 5 nuclei. No, it has only 1 nuclei. And we find these in involuntary hollow organs, such as the stomach, esophagus, and basically the GI tract for the most part. But also we can find it in the urinary bladder, okay? And then the third type, which is cardiac muscle. Now, cardiac muscle is involuntary. We can't control our heart, but what we can notice about cardiac muscle is that it has striations. So there are striations, and it's mononucleated myocytes. It's like getting the characteristics from both like skeletal and cardiac muscles, okay? And then it has also a thing of its own, which is called intercalated discs. Over here, you guys see this distinct purple cuts in between the cells. If you look very close, you guys can see the striations, all right? These are the striations. But then you have this thing connecting two cells. These are called intercalated discs. And these lines, these zebra lines, are the striations. Don't tell me this is the striation, okay? Don't mix them up. This is intercalated disc. This is the striations. All clear? And of course, where will we find cardiac muscle? In the heart. And that's it for the muscles. Now we're going to move on to nerve histology before we go over to hematology. Any questions so far? Am I going too fast? Is it all good? Is the mic good? Can you guys see me? All good. Okay. Yeah, let's continue. So now we're going to talk about nerve histology. Now, nerve histology can be a little like weird, or like it's just different. It's just, but don't overcomplicate it over you. It's very straightforward, honestly, and you just need to know like these essential slides. So we start off with a multipolar neuron. So if you guys recall, we have a unipolar neuron, bipolar, pseudopolar, and multipolar. And you guys are only, inshallah, gonna be asked about the multipolar neuron in the OSPE because it's the most distinguishable. We will also see the bipolar neuron slide, but for now, this is how a multipolar neuron looks. You have a euchromatic nucleus and multiple cell processes that then become dendrites and whatnot. And this one is found in the cerebral cortex. Okay, it's very straightforward. And this is the dendritic like processes of Purkinje cells that are found in the cerebellum. These are the Purkinje cells, okay? And these web-like things that are protruding through the tissue are the dendrites that are caused by these Purkinje cells. Again, this tissue is found in the cerebellum. Now, this is kind of a low yield slide, honestly. Like you may get this and not this, but if you ever see this, hopefully it comes full picture. And also remember, you guys will not be able to see those labelings. Like we didn't cover them up for you guys, but in the exam, they will cover them up. They'll give you arrows, but they will not give you these labelings. So that's pretty like common sense. So just be familiar with this slide in case it comes. And what you need to know is that these are the dendritic processes of the Purkinje cells in the cerebellum. And they are unmyelinated. Then this slide is very high yield. It's the spinal cord slide. And it's pretty straightforward, right? Like you guys saw this in gross anatomy. Now we're looking at it in the microscope. And it has its own like unique stain. So it's looking like this orange black. And you have gray matter and white matter. And maybe they're gonna like point at the gray matter and ask you what this is. They will not ask you ventral horn, lateral horn here. No, they will ask you about the cells maybe that are inside. So for example, gray matter contains large multipolar motor neurons. And then you have white matter where you don't have to like worry about the cell type. Now we're looking at the peripheral nerve, and this would come out of like one of those ganglia, like remember your peripheral nervous system. And this is how it looks like under a microscope. So these are the characteristic features that, let me just zoom out. These are the characteristic features of the peripheral nerve. So we have like a node of Ravier right over here. It's like a dip in the myelin sheath of like two nerves. You guys can see the axon here, the myelin sheath, obviously, and the Sichuan cells. Can you guys tell me what the function of a Sichuan cell? What does it do? Quickly, like in the chat, maybe. Production of myelin sheath, exactly. So we can see one right here, and it's responsible for making this myelin sheath. But the node of Ranvier is just the meeting point of, let's say, two nerves. So it's going to be a dip in the myelin sheath, or it's just a dip in the myelin sheath in general, okay? And this is a very high yield slide. I think it came last year for us. So be very familiar with it. Don't think this is muscle. No, there are no nuclei here at all. And when you see the node of Ranvier, it's very like, distinguishable, let's say. Now we said we saw how a multipolar neuron looks like. This is a very like also isolated multipolar neuron. And over here we have a bipolar neuron in the tissue. So from here, you're going to see the slide again in CVP, by the way. This is the nasal area. And bipolar neurons are found in like adjacent to olfactory epithelium. This is one, and this is another one. And they have a single dendrite and a single axon. They are sensory neurons, they are not motor neurons, and they are found in the nasal cavity. So if you guys see this slide, like there isn't really a way for me to identify like you can really try to make up the axon and whatnot, but for the most part, try to memorize the slide. It's kind of low yield in FND, like it's not probably gonna come, but if it came, immediately think bipolar neuron and think olfactory epithelium and sensory stuff, okay? Sorry for typo, yeah, don't worry about it, man. And this is, like, again, we're looking at the myelin sheath, but can someone tell me what, like, cross-section this is? So this is exactly the same as the one we saw previously, but it's a different cross-section. Exactly, it's a transverse cross-section. So let's say this is our nerve, okay? The one that we saw earlier, this one, it's taken like this, okay? It's just longitudinal. But now we took one that is transverse, and you guys can see the very fine structure of like the nerve fascicles and how they are like bundled up together, okay? They're literally like when you take a wire and like cut it and like you see all the tubes, it's literally like that, spiral line. Well, we kind of imitated it, but you get the idea. So we start off with, of course, you have the nerve fiber, okay? Like nerve fiber is the smallest one. And we can see the myelin sheath and the axon, like the myelin sheath surrounding the axon. And you can still see the Sichuan cells. So this picture is the magnification of this patch. And this one, let's zoom out a little. Each single and like neuron or like axon is then surrounded by endoneurium. Okay, so endoneurium is surrounding each single axon and like with the myelin sheath in it, and then you're gonna have perineurium surrounding the fascicles. So a bunch of endoneurium surrounded axons is called a fascicle, and they're gonna be surrounded. So it's literally like a hole, and then we're gonna surround it by a bigger one. We're gonna like jumble them a lot together, and then we're gonna surround them all. Okay, and this surrounding is gonna be called the perineum. And then this surrounding will also be compacted and like jumbled all together, and we're going to be again wrapping them. And that's called the epineurium. Okay, so epineurium is the biggest, then perineum is intermediate, and endoneurium is the smallest. And keep in mind the epi, peri, endo suffixes because they keep on coming again and again in like CVP, repro, and so yeah, just keep them in mind. Are these unipolar or pseudo-unipolar neurons? I don't think you can really tell from here, but maybe they are, like, I can't give you an answer, honestly. I am not really sure, but maybe they are unipolar, okay? So this is it for the myelin sheath transverse section. And now we hit a checkpoint. We are done with foundation. Now we're moving on to hematology and lymphatics. So any questions? Any questions regarding the parts that we covered so far? If not, we'll just continue, okay? Nope, alhamdulillah. Yeah, let's move on. You guys have precious time to study. So now let's talk about hematologic morphology. So when we're talking like when you do a CBC and you're looking at blood cells, you're gonna have to identify each single one. So you have like red blood cells, white blood cells, platelets, and you have to tell them apart under a microscope. So this is the point of histology after all. So let's start off with the first white blood cell that we are differentiating, which is our neutrophil. The neutrophil is the baseline, like it's so simple, okay? It's just a polysegmented nucleus, and you can see granules in the cytoplasm. So we have 1, 2, 3 lobes of the nucleus. It's not multi-nucleated. This is one nucleus that's just segmented or like to 3 parts, okay? It's not 3 separate nuclei. Got the idea? Now, over here we are seeing too many neutrophils. Why do we have too many neutrophils? Number one, I hope we all can identify that these are neutrophils and not mistake them for anything else. Bacterial infection, perfect. Neutrophils are known to fight bacterial infection and are responsible in the inflammation response. So when you have either, you're going to have neutrophilia. You're going to have an increased blood count of neutrophils. Over here, we have an eosinophil. If you guys have seen under a microscope, it's very pinkish. That's why we call it eosinophil. And it's pinkish stain. There are a lot of granules in the cytoplasm. And yeah, it could be 2-lobe nucleus, not more. So pretty easy and straightforward. And over here, we can identify a lot of them. These are red blood cells, and these are the eosinophils. So we are having a case of eosinophilia right here. Now, recall the action of eosinophils. They are responsible in fighting against parasites. So they're going to increase in number when you have a parasitical infection, okay? And also in asthma. That's just the indications. Let's see. And allergies, yeah, pretty much. But for the main part, like the most important indication is parasitical infection and IgE, major protein, what was it called? Major something protein, yeah. It's going to increase in number, and that's how they fight against them. Over here, we have a basophil. Major basic protein. Thank you, Yasser. Yep. Over here, we have a basophil. Now, we said an eosinophil is pink. A basophil, it's going to be very purplish in stain. Meanwhile, the neutrophil, it's somewhere in between. It's not that, it's not leaning to either. Mashi? And we can still see granules over here. And that's the characteristic features. So when we have too many basophils, it can be a case of chronic myeloid leukemia. Mashi? Remember, it's just a given. You have too many basophils, chronic myeloid leukemia. For you guys, it's a given, okay? You don't have to stress about anything else. So let's just revise real quickly. Neutrophils, they are polysegmented, 3 to 5 lobes, and they have granules in their cytoplasm. When we have too much in them in the blood, we're fighting bacteria or there's an inflammation. Eosinophils are pinkish in stain, and they have 2 lobes and granules in their cytoplasm. When we have too much of them, we're fighting a parasitical infection or asthma, or we're having an allergic reaction. Basophils, they are purplish in stain, and they also have granules. So when we have so much of them, we have a case of chronic myeloid leukemia. Now, here we have a lymphocyte. We're still talking about white blood cells. Lymphocytes, they are pretty straightforward. They don't have granules, so we can see a clear cytoplasm, and they have a circular nucleus. Why does the nucleus matter? Because a monocyte also has clear cytoplasm, but it's a kidney-shaped nucleus. So don't mistake between them. Mashi? Now we move on. We're done with leukocytes. Let's talk about platelets. Platelets are like the easiest thing to identify ever. They're just like small debris found around RBCs, and they're just really cute and just small, okay? But they come from this mess, whatever you want to like describe it. It's just a large purplish haze, which is the megakaryocyte. And this mess of a cell then gives us these cute little platelets that save our lives. Okay, this is the easiest slide ever. Wallahi, this is the easiest slide ever. If you see this, immediately megakaryocyte. Don't ever think about anything else. This is just immediately megakaryocyte. Now let's talk about what we have over here. You see, do you guys see those protruding like, hold on. Okay. Can you guys see those like protruding sharp things? These like rods, these are, I don't know how to say this, ore rods, okay? These are ore rods. The rod-like structure is inside the cytoplasm of a myeloblast. So this is a myeloblast that will then differentiate into a neutrophil, eosinophil or basophil. But it's atypical, it's abnormal because we are having a case of acute myeloid leukemia. Let's see, there's a question. Yes, sir, they're rods. Perfect, you guys can see them. Immediately, this is exactly similar to the basophilia. If you see so many basophils, think chronic myeloid leukemia, CML. If you see or rods, immediately AML. Okay, don't even waste your time on it if you see only histology. So now let's play a little game. Let's start guessing each cell here. So who would tell me this cell right here, top corner, top right corner? What about ALL? You got for you guys' level, you didn't take each differential like per condition. Like you don't know how each condition looks like under a microscope. I don't know either. We only took CML and AML. This is for FND. You guys will take this in third year. So don't rush things, okay? Just calm down. You guys are saying eosinophil. Someone said band cell. This is not a band cell, my friend. This is a eosinophil. And why is it an eosinophil? Can anyone like summarize for me real quick? Thin granules and two loops. Thank you. What about this one? Let's do this rapid fire. Tell me why and the thing, okay? So basophil, why? You guys are correct, but tell me why. Granules, blue granules, perfect. What about this one? This one right here. Can be a little hard. Lymphocyte, exactly. Perfect. And this one? MashaAllah, everyone is getting it. What about this one? Neutrophil, thank you. And I think this is also like maybe a precursor of this is maybe a myeloblast. And this one is a stab cell. Thank you guys. Oh, it's perfect. We're gonna like cover the band cell later on. Wonderful. Inshallah, it's gonna be very simple. Like they're gonna bring you either of these four. Okay, it's not gonna be confusing like between these two. Wonderful. What about this thing right here? Can any smart person tell me? Platelet. Wonderful. You guys are saying, and no, it's this one is a monocyte. It could be a monocyte. I'm not really sure. I have to revise the slides later. But if it's written, if this exact image is in your slides, because I took it also, but I forgot what that was. If it's in your slides and it's saying monocyte, then it's a monocyte. Don't stress about it. Yeah. Let's move into anemias. So in your OSPE, you may be asked about anemias, but how will you be asked about anemias? They're not going to ask you about the physiology of it, like how it happens and how is it affecting the body. No, they're just going to ask you about its features and how it looks like under a microscope. So over here, we have a case of iron deficiency anemia. And it's very like you need to know the morphology of the anemias. So iron deficiency anemia, as you guys can see, it's hypochromic. We don't have a lot of hemoglobin because there's not a lot of iron to make the hemoglobin. So it's going to be hypochromic. It's going to be empty. It's not going to be as reddish. And the cells are going to be tiny. They're going to be small. So it's hypochromic, microcytic. We can see a decreased reticulocyte count and decreased ferritin. Is there anything you have to know about lymphocytic leukemia? For OSPE, I don't think so. Lymphocytic leukemia, you guys, so CLL and I don't think so. Like if it's I went through all of your slides and this is what I gathered for OSPE, so I don't think it's gonna be asked. Inshallah. Right. And of course, iron deficiency anemia is caused due to iron deficiency. Now, what do we have over here? What do we have over here? We have sickle cell anemia. and we have sickle cell shaped cells, and sometimes you can see teardrop cells. The this is the identification. It's very straightforward. It's one of the most high yield questions that they may bring you. So I don't think they're even. I don't know what they're gonna bring you honestly. But sickle cell, you need to know the cause of it. Maybe they're gonna ask you in the OSPE. So just be very they're gonna ask a very simple cause question. So you're gonna tell them, oh, it's genetic substitution of iron. Iron deficiency. Maybe they're gonna ask you, so it's iron deficiency. It's pretty straightforward. And thalassemia minor, it's hypochromic microcytic. It's similar to iron deficiency, but this one is genetic. بينما iron deficiency can be acquired because if you're not taking enough iron. Any questions? What about target cells? Yeah, target cells are also in sickle cell anemia. Can someone spot one for me? There we go. There's one. I forgot to add it. Sorry, guys. So we have target cells, teardrop cells, and sickle cell shaped cells. All good? Tamam. Adam, charger. All right. Is it type C? Okay. Can you guys hear me? Tamam. We're back. So now we have a case of megaloblastic anemia. When we are looking at this neutrophil, it's not polysegmented, it's hypersegmented. Like it is polysegmented and it's taken to the next level. It's hypersegmented. We have around 7 lobes over here, and that's not normal. The normal is 3 to 5. So, and if you guys also compare it relatively, it's very large. And we call this macrocytic anemia. And the causes of megaloblastic anemia, B12 deficiency, folate deficiency. I think that's about it. Aplastic anemia is pancytopenia. Can someone tell me what this fancy word means? And the bone marrow is characteristically empty, filled with fat tissue. There's few hematopoietic stem cells that are CD34 positive in the bone marrow, and the causes can vary. It's idiopathic. There isn't like a specific cause. Let's see, low WBCs, RBCs, and all of that. Perfect. You guys know that fancy word. Pause. Let's move on. Let's not out of time. Let's just Asteria again. The anemias. We have iron deficiency anemia. Teardrop cells, hypochromic microcytic. That's the morphology. Morphology, they can ask you about it. They can be like, okay, what are we looking at here? And another question can be like, describe the morphology. So you have to tell them hypochromic microcytic. Sickle cell, you can't really describe the morphology. So you say sickle cell shaped cells. And this is how it looks. You can also see the teardrop cells and the target cells. Thalassemia minor, it's hypochromic microcytic. Megaloblastic is macrocytic. Hypersegmented neutrophils can be found, and these are the causes. And aplastic anemia, I think this is the morphology. It's just pancytopenia. خلاص. Now we have a left shift neutrophil. This is very low yield, okay? Like, I don't think they're going to ask you about this, but in case they did ask you about this, this is a neutrophil. This is not a monocyte because of all these granules, right? And it's left shifted. There's a lot of granules because of toxic granulification. And this is an active neutrophil. It's fighting infection. This one is also a more severe case, and it's called cytoplasmic vacuolization. I think they did ask us this last year. So maybe they can ask you guys about these two things, but just keep them at the back of your mind. Don't ignore them. Just keep them there. Again, this is when it's fighting infection and it's toxic granulation. So we're having like reactive oxides and whatnot. And yeah. Now let's talk about leukocytes, like cases in leukocytes. Wait, can you repeat? Repeat what exactly? The left shift neutrophil? What's pancytopenia? Okay. Pancytopenia is a decrease in all type of blood cells. So it's not just anemia. Usually it's a decrease in red blood cells, right? Over here, we have a case where everything is decreased. White blood cells, platelets, and red blood cells. ماشي? The bone marrow is itself deficient. That's why we are like having a low blood count of everything. Like over here, we have a lot of mature lymphocytes. Oh, there was someone who was asking about lymphoid leukemia. This is to answer your question. Sorry, I forgot about this. Like over here, we have mature lymphocyte. This is, which is basically when we have a lot of lymphocytes and they are, and it's similar to eosinophilia, basophilia, and whatnot. We have a lot of mature lymphocytes, ماشي? And the causes is infectious lymphocytosis or chronic lymphoid leukemia. This is not normal. This is how it looks. It's like you guys can still see there are no granules of the cytoplasm, and it's red. And it's like it looks angry, honestly. This is another atypical lymphocyte. It's not mature. It's atypical, and like the characteristic thing about this, like this, it looks very identifiable. Okay, when you see this immediately, it's infectious mononucleosis caused by EBV. ماشي? So maybe they'll show you this picture. I think they did get us this last year. Maybe I'm forgetting, but they'll show you this picture and they're gonna be like, what causes it? First of all, you're gonna tell them this is an atypical lymphocyte shape caused by infectious mononucleosis that is caused by EBV. Okay. So once again, chronic lymphoid leukemia can be a cause, like causes mature lymphocytosis. Now monocytosis, we have a lot of monocytes. Monocytes, they are key and like they're a key player in fighting mycobacterial infection. And also they can be increased in number when you have a chronic infection. Tamam? So mycobacterial, it's a type of bacteria. You don't have to go into details, but it's not as normal bacteria. When you have normal bacteria, you're going to have an increase in neutrophils. But when you're fighting mycobacteria, this special kind of bacteria, you're going to have increase in monocytosis. You guys will take this in POD. Are band cells left shift able to fight infections too? Now, band cell is still an immature شو اسمه, it's still an immature يعني segment, like it's still immature. Okay, it's not the final product. Yeah, it's an immature neutrophil, eosinophil, or basophil. So until it becomes, then it can fight the infection. But a left shift neutrophil is actively fighting. So you can't say this is a band cell. No. A band cell is immature. It can't fight infection. So is anything confusing? Am I going too fast? Are you guys fine? Everyone's okay? All good. Yalla, let's continue then. Now we're done with leukocytes. Let's just jump over quickly to hematopoiesis. Now the proerythroblast, like the only way they'll ever bring this is if it's next to another cell. So that's the way you can really identify and distinguish how big it is, okay? Yeah, and it is a very big cell, but alone you can't really tell. Maybe it's just whatever. But over here we can easily tell this is a really large boy. So we have an eosinophil right here, and I think this is a this is a lymphocyte. So comparably, it's very large and it's no cytoplasm, no granules. It's very early on. Mashing. Then we have reticulocyte. This exact picture, they'll bring you. If they're gonna ask you about reticulocytes, they will bring you this picture. Why? Because it's the supravital stain, and they maybe ask you about remnants of DNA and whatever. So reticulocytes, they are the step before mature erythrocytes. They have no nucleus. They have remnants of DNA, and I think also RNA, but they're still not immature. So until they get rid of all the DNA, then they become erythrocytes. And we can only visualize them through the supravital stain. It's a little low yield, but I don't know. I remember they brought it up last year. What's the difference between lymphocyte and monocyte? To answer your question, we have to go back quite a way. And whoa. Hold on. Okay. So this over here is our lymphocyte. And this is our monocyte. I want you to tell me the difference. Both of them have a clear cytoplasm, but their nucleus is the different. That's the way. That's how we distinguish them. Okay. No, you don't have to apologize. I'm joking. Tamam? So a monocyte has a kidney-shaped nucleus, but a lymphocyte has a circular-shaped nucleus. All good? I know it can be a little confusing, so don't get them mixed up. I hope. Okay, let's try to go back to. Whoa. Right here. Someone wanting to ask a question? There's an unmuted mic. All good, yellow. Over here we have a band cell. So again, a band cell is an immature final stage neutrophil, ماشي, or basophil, whatever. So it has a kidney-shaped nucleus and granules. So the way we can distinguish between all three is essentially this. This right here, hold on. Can you guys see the drawing? You can, tamam. This right here is our granules, and then we have our kidney-shaped nucleus, and then we have one with normal kidney-shaped nucleus. And I don't know why I drew a third one. So this one is our band cell. This one is our monocyte. You know what? And this one is our lymphocyte. So this is lymphocyte. This is a monocyte. And this is our band cell. So right, these two have a kidney nucleus, kidney-shaped nucleus. But this one has granules. This one does not have granules. All good? Tamam. Let's move on. So we're done with hematopoiesis. Now we're going to talk about blood grouping. And yani, it's going to be very straightforward, inshallah. They're going to just bring you either this kind of like test or this kind of test, mashing. And let's just go with each one. So let's say these tests are the anti-test. So we have the antigen on the red blood cells. We are adding the antibody. So if we have a reaction, we have the antigen. Tamam? In the first slide, we have, like, this is the same blood. We have a drop here and drop here. When we add the antibody A, we have a reaction. But when we add the antibody B, we don't have a reaction. So there's no B antigen, but there's an A antigen. So this is type A. Second one, it's the opposite. We have a reaction over at B, but there's no reaction over at A. So this is type B. And let's say we don't have a reaction at either. So there's no antigen A, no antigen B. It's type O. And if we have both reactions, so this antigen A is present and antigen B is present, then we have type AB blood. Now, this type of test does not give you the RH factor. It doesn't tell you positive, negative. It just tells you the antigens. Over here, this test tells you everything. And this is the RH factor. This test, when the thing is at the top, it's positive, and when there's like it's at bottom, it's negative. Mashi? So here we're testing for the antigen, and here we're testing for the antibody. Here we have antigen A positive. Here antigen B is negative. RH factor is positive. Ignore this. And antibody A is negative. Antibody B is positive. So let's just map out all the details. We have antigen A and antibody B, right? So antigen A, immediately your mind goes A antigen. If there is no B, then khalas, immediately it's A. And RH is positive, so A positive. I'm going to go to the next slide, but I'm going to delete something from it, and then you guys are going to tell me the answer. Yalla, let's see you guys. Tell me what the answer is in the chat. in OSPE, are we going to be asked about any cytosis and polynucleocytosis? I don't think so. B positive. Okay, perfect. You guys all got it. And let me just return it back. So it is B positive. Over here, we don't have antigen A, but we have antigen B. And we have antibody A, no antibody B. Because if you have antigen B, why would you want to attack yourself, right? It makes sense. So we have B blood type, and the RH factor is positive, B+. It's very straightforward. And this is the last one. We don't have antigen A, we don't have antigen B, but we have antibody A and antibody B. So it's O blood type and it's positive. Does anyone have any problem with this? You guys should not lose any marks on blood grouping, inshallah, okay? Will they ever ask us about the sugar and the antigen? In OSPE, I don't think so, because that's a little too. And OSPE asks about, that's too chemistry, that's biochemistry. OSPE is asking you about morphology, about the structure and how it looks, and maybe any clinical significance. What you're talking is more so biochemistry. I really hope they don't bring it in the OSPE, because they can do anything, honestly, but most likely they will not bring it. Can you please repeat gel card quickly? I always get lost in it. This one? Are you talking about this one? This one? Okay. Again, let's just do it one more time. Okay, let me just delete what I drew. Okay. Over here, these two are testing for antigens, and these two are testing for antibodies. And this is RH factor. So when you have this on top, it's positive for the test. And when it's at the bottom, it's negative for the test. So you tell me now. First column, it's testing for the A antigen. It's positive. We have the A antigen. We don't have the B antigen. There is no B. There is an A antigen, there's no B antigen. And because there's an A antigen, working backwards, we will not have a antibody, but we will have a B antibody. So A antigen, B antibody, that's characteristic of blood type A. And the RH factor test is positive, right? So is it clear now? Do we have SAQs in OSPE? طيب, guys, you've been asking lots of questions about the OSPE. We're going to have at the end, we have 18 questions that are basically OSPE environment. Actually, we're gonna show you exactly how the OSPE question will come. So be patient until the end and we'll answer all of your questions. Now, onto the final boss, the lymphatic histology. Now, the lymphatics are a bit confusing, so hopefully we summarize them really nicely for you guys. And we start off with the most simple lymphatic structure, which is the lymphatic vessel. This is a lymphatic vessel, this is a nerve, and this is an arteriole. This is a venule. How do you, first of all, separate between blood vessels and lymphatics? Blood vessels have blood in them. They don't have blood in them. They only have a lot of fluid, which is lymph fluid. If you have blood in your lymphatic, something is very wrong. Okay? Exactly, have lymph. So they are a single lined endothelial, they have a single lining of endothelial cells, and they carry in with them out of lymphatics, lymph juice. So they are way bigger than venules and arterioles. And as you can see, arterioles have multiple layers. Venules have a single layer. Lymphatic have a single layer. How can you distinguish between lymphatic vessel and a venule? Again, the blood. Here we have blood cells. Here we don't have blood cells. Like, you guys can really see the blood cells here. Hopefully all is good. Now we're gonna talk about lymphatic secondary nodule. This structure right here can be found in many places. It can be found in the thymus, it can be found in the lymphatic node. So know how it looks and know its function. It has a germinal center where the active lymphocyte proliferation and antibody formation takes place, which I think you guys took basics in that in immunology. So we're gonna have a lot of B lymphocytes there, okay? And then we have surrounding like the germinal center, something called the mantle zone, which is this is not lymphocytes, this is just kind of tissue. And the lymphatic secondary nodule is not capsulated. So we can find it inside organs. It's not its own organ. We can find it inside organs that are capsulated. Is everything okay? Are they mature in the germinal center? Some are maturing and some are mature. Those who are proliferating are splitting and becoming mature, and the ones that are making antibodies are the ones who they are mature and they're working. The mantle zone doesn't have T cells. I don't think they do either. Is this in the thymus? This could be the thymus, or it could be in the lymphatic node. We're gonna look at both. Now, moving on. This is a thymus. Memorize this slide. I think it's gonna come in your OSPE. It came in last year, and it's very identifiable. Okay, the thymus, like this is the color of it. This is the structure of it. And it has a cortex, a medulla, trabeculae, and hustles, corpuscles. These are basically the identifying features of it. And it also has a capsule. There was a, okay. Let's start breaking down the thymus layer by layer. So this is the thymus from all, like this is the top view of it. If we go a bit deeper, we can see the capsule and other stuff. So for example, the trabeculae, the cortex, and the medulla. Now, this slide, I don't think they're gonna bring, but if they brought, no, we're in the thymus. Blood vessels are on the outside, and the trabeculae is connecting them. So we have like sinusoids and whatnot. And the cortex is, so basically this is how a cortex and medulla looks like. Now, you guys should be familiar with this concept because it keeps reappearing in whatever organ you're studying. So for example, the kidneys, the adrenal medulla, the adrenal gland, and glands in general. So the cortex is the outer covering, and the medulla is usually the parenchyma, which is like the functioning type of cells. So again, we have the capsule. Let me just try to draw it. So let's say this is our thymus. It looks like a liver, but then we will have a capsule over it. And then on the inside, okay, this would be our cortex, and this would be our medulla. So capsule, cortex, medulla, from out to in, like from most exterior to interior, capsule, cortex, then medulla. ماشي? And this is the same picture, just magnified, right? It makes sense. This is the picture, we zoomed in. Now zoom more, now we're in the medulla. This is the medulla, this is the cortex. And these are the trabeculae, by the way, ماشي? And the cortex and the medulla, okay, they both have different jobs in thymus. You don't have to go into details when you're tackling OSPE because OSPE is talking about the appearance. So you need to know the cortex holds, it's more so basophilic, and it's darker because it holds a lot of developing T cells. Meanwhile, the medulla is lightly stained and it has less of like the kind of lymphocytes that can be stained. ماشي? So we have lymphocytes everywhere because this is the thymus, it's immunity and whatnot. But the level of color that they can pick up is different. The cortex is really basophilic. The medulla is more so light stained. Whoa. Let's try to zoom in. And then we have these Hassel corpuscles. How do you say it? Hassel corpuscles. Anyways, when you see one, immediately know that you are in the thymus. Now, this is the nice thing about histology. You see a feature, you see a characteristic that is unique to a single organ. When you see this, you know you're in the thymus. When you see Peyer's patches, you know you're in the ileum, and so on. You're gonna take examples over and over again and throughout first year, Mashi. So the example we're taking now is Hustle corpuscle that is found in the thymus. It's epithelial reticular cells that are concentrically arranged. You see how it's circular in shape? And they produce interleukin 4 and 7. The function you don't have to really dive deep into for OSPE, but if you know it, it's always it's a bonus, Mashi. Now we're done with the thymus. If you have any questions about the thymus, you guys can tell me now. I'll explain again. Is everyone okay? I think we all are okay, everyone. Does the thymus have follicles? You mean like secondary and tertiary follicles? Does it? Or are you talking about like nodules? Because I'm not really sure, honestly. The parts that you are like, that you need to know are the cortex, medulla, and Hassel's corpuscles, Mashi. And the capsule, of course. Like you need to be able to identify each. And if they showed you a thymus, like they're gonna ask you, why do you think this is a thymus? What characteristic features? So you tell them, oh, it has a medulla, cortex, Hassel corpuscle. Always say that, Mashi. Now let's just cover the tonsils really quickly. And okay, and so we have three main tonsils, right? We have palatine tonsil, lingual, and what was the third one? Pharyngeal tonsil. So this is how a palatine tonsil looks like. Don't mistake this for the, where was the spleen? It's not really similar to the spleen, but don't mistake this to the spleen, okay? It's something else. It's its own thing. It has crypts and like these kind of like deep dives or narrow, how do you say this? Like just invaginations, basically, okay? In the cap, inside the organ, okay? It's just like folds into each other and goes in, it seeps in. So it has, you need to know the epithelium of the palatine tonsil. You don't have to really care about what's going on inside. It's non-keratinized stratified squamous epithelium. That's a mouthful. So let's just try to draw it out. It is stratified squamous epithelium. Okay. Like a lot of squamous layered on top of each other. And it's non-keratinized. So it's just this. There is no keratin on the top. And here's a little fun fact for you. Whenever we have keratin, the tissue or organ or whatever is exposed to air. Okay, so the palatine tonsil isn't exposed to air because it's non-keratinized. You use the keratin to protect against air. And a lot of other stuff saying this is a fun fact. Now, we have also lymphoid nodules in the palatine tonsil, so these are the characteristic features of it. The lingual tonsil and the pharyngeal tonsil, you also need to know the epithelium. Yeah, and honestly, these are really low yield. I really hope they don't bring because they're very confusing. And the only way I can tell you to study them, like the thymus makes sense. Like you can see the cortex, you can see whatnot. But these just try to memorize how they look. Like the exact slide. If they're gonna ask you, it's gonna be the exact same slide. So you see this? It's palatine tonsil. It's not spleen. Palatine tonsil. You see this? Lingual tonsil. Pharyngeal tonsil, they didn't even show you a picture. But you need to know, and it's pseudostratified epithelium. I added this just to like complete the tonsils. It's not gonna be asked in the OSPE, inshallah. Maybe they can ask you how is it different, but I don't think they're gonna bring it up. So lingual tonsil is stratified squamous epithelium. It's similar to this, and like you can really see the epithelium right here. And it's also non-keratinized. But the pharyngeal is pseudostratified. And the lingual is located at the base of the tongue. So we have a lot of crypts. And this one, it's kind of the same thing, honestly. Again, just try to memorize the thing. Meanwhile, the lymph node is very distinguishable. So when you see this, immediately click lymph node. And the lymph node it's similar to the thymus. It has a cortex, a medulla, and so on. So if we look over here, whoa, we try to zoom in, it's capsulated, and we have trabeculae, a cortex, a paracortex, and then you have also like those secondary lymph nodules. And then you have the medulla, which is a bunch of sinusoids draining into each other. Now we're going to zoom in a bit more. We have a structure that is, wait, hold on, let's zoom in into this one. This is again the lymph node. And over here we can really just like, one second. We could really see there you go. Sorry, one second. So like this is the paracortex. This is the cortex, paracortex, and then we're starting to go into the medulla. And in here, we're gonna find a structure. This structure is called high endothelial venule. So these are only found in the paracortex of the lymph node. And they are entrance sites for circulating lymphocytes. You are coming from the outside into the lymphocyte, okay? So you're entering from it and going to the medulla, which will drain into sinusoids and then the lymph circulation and whatnot. And they're also responsible for fluid absorption. They are lined by cuboidal or columnar endothelial cells, if you remember from the epithelium. Okay, so highly endothelial venule, we find it in the paracortex of the lymph node. And this is the same picture but magnified. So if you see this picture, lymph node immediately, you can say paracortex, cortex, and so on. Now, we have the spleen slide right here. And we said the spleen kind of looks like the palatine tonsil. Not really. The spleen, it's not separated into a medulla and surrounded by a cortex. No, it's separated into white pulp and red pulp. Kind of similar to gray and white matter, but it's not surrounding each other. It's more so non-uniform. So all of these purplish stains are the white pulp, and the fill-in, all of this fill-in in between is the red pulp. So the white pulp is lymphoid tissue, and the red pulp is red because it's blood-filled sinusoids and splenic cords. And this is a zoomed in slide. Maybe they'll bring you this and immediately think of the spleen. Actually, again, they're not going to bring you a picture outside of your slides. Never. They're going to always bring you a picture from your slides, from your lab books, and basically it. They're not going to bring you a picture of a spleen they took yesterday and they're like, ha, yalla, take. No, they're not that evil, okay? So, are the white parts blood vessels? Now, the white pulp is, no, it's not blood vessels, it's lymphoid tissue. And what does that mean? So, if you remember the like germinal centers and nodules and whatnot, they're all basically bundles of lymphocytes. And they are all responsible for the immunity, fighting immunity. So the spleen is also responsible in that system. So white pulp is lymphatic tissue. There are lymphocytes here, maybe T, maybe B lymphocytes, and I'll check later exactly what it is. And we have a structure that's unique to the spleen white pulp, which is the so we have a central arteriole right here, and the lymphoid tissue starts surrounding it, and that's basically how the white pulp forms. So again, around it, the red pulp, it's red because there are blood cells, and the white pulp is white because let's say there is lots of lymphocytes. Actually, are the white parts? So no blood vessels. Nope. Okay, there is like a blood vessel. So like there is one right here. It's a central arteriole. But like I don't understand your question. Why does it matter if there's no blood vessels or not? Because of the blood cells? Because of the red? The red ones, yeah, of course there's gonna be blood, but the red ones have actually there's actual blood in the sinusoids. It's not like capillaries, arterioles. venules. There's sinusoids that are filling with the blood. Your blood is going to the spleen and it's fighting infection or whatever. Does that make sense? So we're gonna, like, it's not really filtering your blood, but it's gonna enter through the sinusoids, and then with the white pulp, with the lymphoid tissue, it's gonna fight whatever disease you're having. Okay, hope that makes it clear. Don't like think about the function as much as you need to think about the morphology and how it looks. So we are done, everyone. We are done with OSPE for FND. Round of applause for everyone. But right now, we are going to have like a mini OSPE practice run. Okay? So if you guys want to stay around, inshallah, it won't take long. But if you guys want to leave and study, it's absolutely fine. You guys can refer back to the slides and practice everything. Yeah, don't study from this slide, okay? Use it as reference, use it as a review. Study your slides, study your lab material, and really focus on everything. inshallah يعني best of luck موفقين يا رب والله يكتب لكم الخير يعني. So right now me and Adam, we're going to like have a mini OSPE session. Yeah, thank you very much. So how will we do this? With the mic? Cause I'm going to keep this. لا كلهم مع بعض عادي. So like, with the mic is here? Alright. Let's see. So this is something I explained, and this is how your OSPE will be. Let's again revise what the OSPE is. It's going to be on Examosoft, so it's going to be on your iPads, online, and it's going to be around 20 questions, 30 minutes or so. So there's no backward navigation. What does that mean? Let's say this was a question and this was a separate one. If it was a normal test, I could go back and forth, okay? But this is an OSPE. OSPE, you can't go back to the question. So when you submit, like go on to the next question, you can't go back and revise or change your question. So be very careful with what you write, but don't waste a lot of time on it, and don't stress too much. If you know, you know. If you don't know, move on and use that time somewhere more important, basically, okay? So
don't leave the answer blank. Try to put
try to write up anything that comes to mind. So it's going to be like this. Going to show you a slide and ask you two questions. What is the condition of this patient? And what is it caused by? You see how these questions they're written? It's very about the appearance and the cause. It's very clinical. So can someone help me out here? Abnormal lymphocyte, acute myeloid leukemia. Perfect. Oh, well, almost perfect. I also got carried away, Shui. The acute myeloid leukemia, sorry, it's R-RODS, okay? Over here, we have an atypical lymphocyte, which is also an abnormal lymphocyte. You can use synonyms, that's fine. But it's caused by infectious mononucleosis that is caused by EBV. Okay? Yeah, don't worry about it. But in the exam, inshallah, you guys don't get this mixed up. I know it's a lot of stuff. It can be confusing. I got it mixed up. Inshallah khair. Now, this one, let's see the questions. What is the condition of this patient? Describe its morphology. So clearly this is anemia, but which kind of anemia and what's the morphology? You guys are saying, someone said sickle cell, microcytic hypochromic iron deficiency. Okay. Okay, so the majority are saying iron deficiency, alhamdulillah. It is iron deficiency anemia. And again, it's hypochromic microcytic anemia. Now, it's similar to sickle cell, but not really. Sickle cell, it's not hypochromic. And you can really see the sickle cell shaped. Hona, you can't see that. You can see a teardrop, and also you don't see target cells. Mashi? So don't get them mixed up. And take it away, Adam. Over here, you can make up your question.
If a patient lost all of his sensory neurons, which letter would be damaged? Someone said D.
Someone's saying
E and F are correct. Yes, it's not D.
exactly. This is a double keyed question.
So D in this case is ventral. It's not dorsal because we said the anterior medial fissure determines whether we're anterior or posterior. Okay. So make sure you know where the anterior medial fissure is, and then you answer the question. Okay.
So this is the ventral horn, and this is the dorsal horn. And the sensory are going through the dorsal into the dorsal ganglia. So that's why E and F are correct. Can G also work? Yeah, but we said sensory only. Motor is also going here. Do you have any other question?
No.
خلاص.
That's not it.
طيب. What is the blood type of this patient? What blood types can he not be infused with? Yalla, guys. You guys are saying B positive. And what about the blood types that he cannot be infused with? Can not. Exactly. You guys went into the RH factors, and that's beautiful. Khalas, perfect. Any questions? Any question? Just don't forget to tell them.
Okay,
طيب.
so what's the question here? Okay, so what's the name of this bone and what is its classification?
Just hold on. Hold
So
on.
first off, the name and then classification.
Yeah.
Clavicle, 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 okay.
Modified long bone.
Modified long, exactly. Good job.
Someone's saying irregular
It's not irregular.
or like atypical. Never mind. خلاص تمام. So we all agree. No, number one, this is the clavicle, and it's a modified long bone. No one said it's a flat bone. Perfect.
Okay,
What
so what's
is-
the name of this muscle and what is the muscle fiber orientation? So first off, name. Sternocleidomastoid, exactly. Parallel. Good job.
And they wrote it correctly. In the OSPE, by the way, if you have any spelling mistakes, it's fine.
As long as the word's understandable.
Yeah, I think a lot of us also wrote like all of us just improvised how we write sternocleidomastoid. But it's a very high yield muscle. It can probably come in your exam. طيب. Now, what is the organ in this picture? What's the function of the cortex? Let's see. Yellow, we just talked about this. Thymus houses B cells. Tonsil, I don't know. طيب. When we're talking, so this is, yes, it is the thymus, and it's T lymphocyte maturation. When you were talking about lymphatics, it can get very confusing because everything is purple, everything is pink, you can get lost. So try to revise and memorize the slides very well. Again, over here we have a cortex and a medulla and trabeculae, capsule, whatnot. ماشي? So this is clearly it's clearly the thymus. ماشي, guys? Don't get it mistaken. And again, in the OSPE, they're gonna cover up these labels. You're just gonna get the image, clean image, no labeling, nothing at all. You have to label it for yourself. So we didn't cover it here, but in the OSPE, they will cover it. ماشي? طيب, what is the organ in this picture? What's the kind of nerves that you find in gray matter? Well, this is like very weirdly phrased, very low effort.
By the way, these are past questions. So if you have a question, don't share them with the doctor, yeah?
Yeah, don't show these questions to anybody. Just share them with your batch and along.
Spinal cord.
Okay. Motor
Motor
nerves.
nerves.
And someone said exactly what I was looking for. Someone said MNP, exactly. It's a polynucleated motor neuron. Thank you.
Exactly.
Thank you, Musa. Yalla, guys. What do we see here?
Multipolar neurons. I mean, they might consider it right.
Okay, perfect. Or rods and AML. That's wonderful. See, that question took 10 seconds. Yalla, next one, immediately. What is observed in this picture? Where do we find the structure? HEV, exactly. And we find this in the paracortex of the lymph node. Wonderful. Perfect. Thank you, guys. What is observed in this picture? Where do you find this type of tissue? Reticular fibers. Wonderful. And we find this in lymphoid organs, such as the thymus or bone marrow. Thank you, guys.
What's the
And
question here?
this one.
So what's observed in the picture? We'll give one example of this kind of muscle. So basically, what's the type of muscle that's shown here? Give me one example.
Oh, that's perfect. We got it.
Multiplanate deltoid, exactly.
Well, last one. Yalla, guys, I think this is the last one. So what is observed in this picture? Where is it found?
Okay, beautiful.
Loose connective tissue. Perfect. And it's found under the epithelial lining. Okay, one more apparently. What is observed in this picture? Yalla, guys. Hypersegmented neutrophil. And immediately it is megaloblastic anemia. And read the question very well. What's this condition called and caused by? So we have to say megaloblastic anemia caused by folate
Still doing
retention.
it?
What is observed in this picture? Anemia. Well, basophil is correct, but we have too much basophils. We have basophilia, and it's a case of chronic myeloid leukemia. Wonderful. Okay, I think this question is wrong, so let's just ignore it. I mixed it up. Yalla, guys. You can just say neuron, peripheral nerve, and the characteristic features is basically this. Nodes of Franvir, Sichuan cells, axons, whatever. Myelin sheath.
Cardiac muscle, صح.
Intercalated disc striations. And with that, we conclude our passage. So thank you guys so much for attending. We wish you all the best of luck on the final. We were in your place last year, so we made it. And I'm pretty sure you guys will make it, inshallah. Just focus on your exam, get a good night's sleep, and don't worry about the OSPE. Inshallah, you guys have figured everything out. And this has been me, Firas, and Adam. And if you want to ask us any question, here are our numbers. If you saw us in uni, also don't be shy to reach out. And thank you guys for your time. And inshallah, we'll see you in other class sessions.
Inshallah.
Inshallah.
Pretty soon as well.
Inshallah. Yalla, guys. Have a nice day, and thank you all.
Thank you guys.